Good morning. I've got a couple of announcements. First of all, I mentioned yesterday at the end of the day that if you have any recommendations to go ahead and email those to Arida. What I didn't say was that they don't have to be submitted ahead of time. You can bring them up at the time when we get to that point of discussion. But it's just helpful to them. And also, if you haven't done it yet, they're asking for you to submit it by 10 this morning. So, jumping into the agenda for today, the first item are the public comments. So, as you can imagine, it's difficult to get some of the residents and consumers to provide testimony. And the first person listed there actually has become ill, and so she will not be testifying. We were hoping to have her via WebEx. And so I've asked Camille, the ombudsman, to kind of give us an overview. There are numerous pieces of written-only testimony, and it's kind of difficult to get through those in time for, some of the discussion that we have later. So, Camille, I'll call on you to give us kind of an overview of the written-only testimony and some of your discussions.
Thank you. You know me well. Thank you, Madam Chair, for offering up to let us do this. We appreciate and are honored to be able to come. And as usual, ombudsmen are the voice of residents. We had hoped very much to have someone, at least on WebEx, and several if possible, to at least be on WebEx and speak to us. Ann Rudd was one who was going to speak to us today on WebEx, and she was very disappointed when she fell ill, and she still hopes to have that opportunity sometime in the future. She would have been very good to be able to answer your questions. She is a extremely feisty 82-year-old who would like to share and advocate for others. She, like many people, had something that happened. She had a broken leg and entered a nursing home and found herself not leaving there. And so that is a pretty common thing for us to happen. She likes to advocate for people who have memory issues and not able, and she always tells a story of, an example would be someone who's waiting to go to the doctor and they need to eat first, needs to have lunchtime first. And she keeps trying to get a tray for them so that they could get their lunch eaten so that they could go to their appointment because people are not listening to them. And so that's the kind of advocate she is for her neighbors. But I come to you today, Camille Russell, State Long-Term Care Ombudsman. I'm kind of new to this role. I was appointed in early this year. And the long-term care ombudsman programs are in every state and also in Puerto Rico, Guam, and DC. We operate with a pretty small staff. We have 7 regional ombudsmen that cover 105 counties and over 700 nursing homes, but we do that pretty diligently. So not only do we advocate in nursing homes, but we do like we do today, where we're advocating at a larger level. So I'm happy to be able to be that voice today. It is an honor. It's a humbling honor, and actually it's extremely heavy, because I know that I cannot do justice to what these individuals would say to you directly. I encourage you to consider going and visiting nursing homes personally. And if you would like to have an ombudsman accompany you, we go there to make sure that the people who would like to talk to you get to, and the people who would not want to talk to you do not have to, because that's their right, as a visitation right. So we had several people that were willing to do this. We had a lot more that said they wanted to, and they were afraid. And they said, I'm just not brave enough. And the truth is just even being able to say that's pretty brave, that you're not brave enough. But we have testimony, or written testimony from Colette Carrasco. And she's described by the ombudsman as a strong, kind, confident, and pretty insightful lady. She talks about, though, in her letter, and I would ask you to take time, sometime outside of this meeting, to consider the fact that these are individuals that, put yourself in their place. If you had come here today with what you have with you today, and you never went home, when you leave this building, when you leave this room, or you go to another room that you probably would live in with one of us. I don't know who you'd pick to live with in here, but that's who you would be with. And that you would not have outside. So it was very difficult. Technology is an issue for people to be able to come and testify to you today. Because we no longer have landlines in most nursing homes, if they do not have a cell phone, even being able to take the phone call confidentially and privately was an issue. So they are brave. Anybody that's brave that has done this, whether they have good things to say or not so complimentary things in some cases to say. But Colette talks to us about a theme that we see a lot is about respect. She talks to us about rude staff. She talks about medication mix-ups and then it being so loud that she can't sleep, and she can't get well because she can't sleep, and she is not able to do some of her things that she needs to do to get well, her therapy. So she's having trouble getting home. She said that when the state is in the building, which was kind of what brought this around, that the state is in the building, that things look better, that it should be that way all the time. That when state comes in the building, things get pulled together, but that she'd like for it to look more like it does when state comes in the building all the time. Then we have Helen Davis. Helen Davis is a pretty matter-of-fact lady, and she is a satisfied senior. And she's pretty happy that she doesn't have to worry about running errands, and she's pretty happy that she has activities to do and be able to see people in her home. So she's pretty satisfied with being able to socialize with others that live in her home. We have a young resident, Ms. Friesen. Ms. Friesen, I believe, is in her 20s, and she has found herself resident of a nursing home. We have more and more young residents all the time in nursing homes. She is finding her purpose there by advocating not only for fellow residents, but for staff who she said do not receive enough support. So, Mrs. Friesen. Ms. Headley. She lives in Overland Park now, but she had not always lived in Overland Park. She has found herself the resident of a nursing home, but she'd worked in one for 30 years. She is disappointed. She thinks that she'd like to be the voice of residents because she's not having the same experience in a nursing home there that she worked in for 30 years, and that people were treated like family in the home that she had worked in for so long. And where she lives, she has gone sometimes 2 months without having her hair washed. She has gone up to 3 months without even a bed bath. And folks, this is something the ombudsman have been hearing during the pandemic far too often. She has cut back on her liquid intake. I don't know if any of you, but I actually have made that decision occasionally in these long meetings to not maybe drink as much as I would normally drink. But I can't imagine living that way, that I would know that I might not get changed more than twice a day and that I could not do that for myself. So then I would limit my intake of being able to drink, which of course leads to a lot of the other things that we see happen. We see UTIs, we see those delirium, we see those people who are having difficulty, and sometimes that aggressive behavior that gets talked about happens because of things like that. She talks about it being short-staffed, low on supplies, and poor communication between the staff and administration. And a big problem is the agency staff, that they don't know the residents. They don't know. They can't provide person-centered care if they don't know the person. She says that when she calls the state, and she has numerous times, that she does not see much change, that they're often not able to find evidence of the deficiency while they're there. We have a resident, Serena Mitchell, who has had, her testimony talks about unreported falls and how they have handled them. It talks about vermin like mice in her dwelling, and waiting 45 minutes for call lights. I will tell you, call lights are something we ombudsman hear about every single day. And sadly, and I say sadly, that we had an administrator recently tell us that they were very proud that they had implemented a policy that all call lights would be answered within 20 minutes. I don't know about you guys, but 20 minutes is a long time for some. And 20 minutes is not acceptable under regulation for those kinds of things either. They were very proud of that policy, that they could do that. They don't have staff. They are not being supported by the businesses that own them to have the staff that they need. So Mrs. Mitchell, she talks about a lot of those things. She talks about falling, breaking bones. She is in assisted living, I will say that, and that when she needed to have her tray brought to her because of, some problems that she had, they apparently did that, raising the room fee to $7 a tray for that. You can read her testimony. She has a pretty long list. We have a resident who's a resident council president, Ms. Perry, in Cherryville Nursing Center, she says, and she's the resident council president there, and she does that because she has a positive spirit and she likes to take care of her neighbors. She said when the surveyor's in the building, it's pretty much business as usual. She doesn't really see what goes on because she usually stays in her room, but that she doesn't think anything happens any differently. We have Ms. Terhune. She's not complimentary. She says she does not get her call lines answered, that she has sores, an improper diet that does not allow her to heal. She feels that she would have starved if it would not be for her family bringing her food. I will tell you that we have, during the pandemic, this is something a little bit new. This is not, some of these things have been ongoing pre-pandemic, but some of the things we've seen during the pandemic have been a little bit new, and a lot of that, the food has come up more often. Not, they don't complain about the quality of the food now, they literally are complaining that they're not getting food, that trays are not being delivered, they're not getting food, or that the meal is fixed, but they didn't get the meat because the meat didn't come and they didn't do anything to replace that. So those are some of the things that we're hearing a little different with the pandemic. They said that it's really not any different when state surveyors in the building. Then we have some family members that also did, and they reiterated. Ms. Boyer talked about missed meals for her mother and that she provided the meals for her mother. Communication is a big and a constant thread between nursing homes internally within the nursing home and then nursing home to family members. That is something that absolutely, I'm sure, can be improved upon and would help in all cases. She said that management pitches in when state is in the building. That's a common thing that we do see as well. We have a statement from Dustin Baker. Dustin Baker is an intelligent, tenacious advocate for his grandfather, Larry. You may have been on a committee that has heard him testify before. He also will be an advocate for other residents. His story is, and also a common one. His testimony, if you would read that, is one that you could probably take the names out, and is something that we see and hear all too frequently across Kansas. His father, or his grandfather, was experiencing, he was complaining about disrespect, and I'm sure he may have been described, I know he was described sometimes as being aggressive over that, but very simple things that he indicated was disrespectful, but he also has some impairment that impacts his ability to process that and how he deals with that. And so in failing to get that addressed, he was sent to a behavioral unit, a Jerry Psych unit. In the Jerry Psych unit, then he had a medical condition that got him to a hospital. And the nursing home decided to take that opportunity inappropriately to say they were not going to allow him back in the nursing home. He wanted to go back to that home. And were not for the strong and tenacious advocating of his grandson, he would have ended up like many residents that just would have been moved to some nursing home, probably far away from family that did not get to see him. And we often see that happen, and it is all too common for there to be had negative physical effects of that, and up to including death of constant moves. And so he was an advocate. He fought. He used his appeals process. He used the administrative process. He worked with surveyors. And finally, at the last moment, the nursing home, 3 months later, his grandfather lived in a hospital for 3 months. 3 months later, he was accepted back into the nursing home and has actually done pretty well then, since they realized that some person-centered planning and addressed to some of the things that he needed were workable. And so we appreciate the advocacy of Mr. Baker on behalf of his grandfather. And he has his phone numbers. Many of these people have put their phone numbers as well, and he will take calls from any of you, I know, to talk about the details. We have a husband and wife whose daughter, and they talk about, again, they're wanting to support staffing. There's a theme of all of these, that the staff need better support, that there needs to be more staff, that they need to be trained and educated in a way to know how to support residents in the nursing home well, and that we can improve leadership in supporting them, the management. So that was the theme of Mr. Friesen. We have Judy Garrett. This is another one. This is another one that and this is antipsychotics. I think, it's not really blatant in here as you look at this, but our charge is to look at that as a part of our task force. And this is another one that if you took the names out and you read the story, Judy Garrett, for her father, Edward Roush. Edward was a larger-than-life, jovial gentleman. I mean, he had a gentle spirit. Edward Roush is no longer with us. And if you will read his story, and you will see that all too common, it is one, again, we could take his name out. He went in a nursing home. He had some issues where he went 72 hours without sleep. Well, when we go 72 hours without sleep, other things happen. So then he was agitated, and while that got addressed, and he got something to sleep, and he became back to his own old self, the nursing home still felt that they wanted to send him to the jury psych. He was sent to the jury psych unit, actually against the family's wishes, but they finally realized that they didn't know they had a right to choose not to. And so they said they would take him. He talked there on the way to the jury psych. He was able to ambulate himself, walk himself with a walker, and he was pretty jovial, they said, on the way there, that he talked to someone on the phone that called him and talked about hoping to get back to his own self, even be able to play golf at some point. They visited him daily. But in 10 days at the jury psych, when they went to pick him up to take him back to the nursing home, he could no longer use the walker to get to the car, and it took 3 staff to help put him in the car. So he was no longer able to talk. They laid him in the bed. He wouldn't wake up. They insisted that he go to the hospital. And they were able to get him back into a state where they could move him to another nursing home closer to them and into literally another state, Oklahoma. But 1 month after being discharged from the hospital from that 10-day stay, he died. And they just have a hard time understanding how those things can unravel so quickly. And yet his story is one that we see of many residents. Another, Ms. Kaiser says that the locking out, and by the way, they're not supposed to be locked out anymore. Visitation is open. So if we have nursing homes that are still locking people out, not the thing to do. Visitation is supposed to happen. But the devastation that happened from locking out family, particularly with people with dementia who don't understand, she said just was devastating. And that she believes that more training for staff, particularly in the dementia area of dementia, would be helpful. We have Mr. Randall, who has a wife he's been married to for almost 58 years, who has Alzheimer's. He says she has wonderful care at the facility and has never had a concern since her admittance. And yet, the isolation of having been locked out has had pretty hard effects on her and on her family. He has a lot of compassion for that nursing staff there and does know that we need more nursing staff. We need to make it easier for nurses to come into the field, less expensive and less hard. We have Miss Slattery. Miss Slattery is talking for her mother, Nora Kemp. Nora Kemp also has passed away during this time of COVID. And their experience there, she explains their experience there of numerous complaints and numerous issues and poor communication. Communication issues were probably her number one, lack of trained staff, that they reported care issues, and though care plans were adjusted, they just weren't followed. They did report to the state, and initially they did not hear anything ever back from the state when they made their report. But after some learning how to maybe go about that, then they were able to be, even though they were their reporter, they were not contacted by surveyors. So I will say it was with some assistance from our office that we did talk to them, and surveyors had indicated that the reporter should be contacted, but oftentimes we find that is not the case. So with some help from our office, she was then able to speak to surveyors when she made subsequent complaints. She still did not ever hear about things that happened as a result of the survey, but she was able to talk to them and provide her information. On that communication, there was a time that that facility actually told her and all of their family members, it's like, you can call, and then we will answer you within 72 hours. Well, when you have a mother in a nursing home that you don't know from the start of the day to the end of the day sometimes, their state of being, and you're told you can call and leave a message and we will call you back in 72 hours. Mrs. Tones. Mrs. Tones, she lived in her own home in Andover. Her husband has Alzheimer's, and she talks about how the isolation has been very difficult, that his his care level, even in the same home, is how it's so much different between the memory care unit and outside of the memory care unit. She's not aware of any survey process or inspection process that exists. But she does know that there's not enough staff, and she's seen one aide attempt to feed as many as 3 residents at the same time. I'm not sure how that would have worked with COVID and the precautions, but she probably wasn't able to be in the building much during that time, so we don't know how that was happening then, quite frankly. She talks about cost and how they've, her trying to live on the amount of money they have with him in the nursing home. We have Kitten Warren, and she is the daughter of Joyce Snyder, who lives in a nursing home. She talks about the facilities being understaffed and not properly trained. She talks about the biggest issues being communication. This is a theme that we kind of saw. And I want you to know, that of these 17 individuals, we took it as they came. We are ombudsmen, and that's what we do. We listen to people, what they tell us. We take what they say. These are not a select group. These are the 17 people who said yes in a short amount of time. And I am proud of my ombudsman, and I thank them. I told them on a Monday morning that we were asked to do this. And again, 7 of them, 105 counties, or 700 homes. They did a great job coming up with 17. I thank the committee for listening today. I thank the committee for thinking about these issues. Consider yourselves. We're going to be there. When I was told I would be appointed to this job, the same week I was told I had cancer. And it didn't scare me that much. I thought it's just one thing to do. I can do this. And then I had the hearings, I was appointed, and I got the job. I will just do this. I will just do what I need to do. I had major surgery, and I went in, and even that morning, I was not afraid. I will just do this. And I felt like I was in good hands. And I've got to tell you guys that when they said, I have some blood pressure problems, and they said, you need to be careful, you're going to have a stroke. And my mind immediately flashed to that person who has a stroke. Could be any of us, any day, and they're in a nursing home. And I was afraid. And I am rarely afraid. There are good people working in nursing homes. There are good people owning and running nursing homes. But we can do better. We shouldn't have some of these things that we're hearing happen. Thank you today. I stand for any questions, but thank you for your time.
Thank you, Camille. I think we'll hold off on questions till we get through
Thank you.
the rest of the list. But I appreciate you going through those for us. Next up, we have Jan Kimbrell. Excuse me. From our task force, who is going to speak to us as a private citizen. And I really wanted to hear her testimony this morning because it might be something that we will be discussing this afternoon.
Thank you.
So,
I appreciate that. I am Jan Kimbrell. I live in Morris County. I'm a member of what's called the Kansas Silver-Haired Legislature. We're an advocacy group. We're not lobbyists. But I'm here today because I'm over 65, and we're trying to age in place in our home in Morris County. And we've done all the things in preparation to adapt our home and take care of ourselves and do all what we can do. And but the community, the state has not kept pace with the changes in medical technology. Everything seems to be going the telehealth route, and I'll talk about that in just a minute. But I want to tell you, as a little bit of background, that not only am I, an old woman in trying to age in place, but we have 40 years experience in healthcare, my husband and myself, and in clinical and in administrative, and we thought we kind of knew how the system worked, and we knew how to play it and how to get around it and dodge it and do what we needed to do to have quality life and help people that needed assistance to know how to jump through the hoops, and we did that for quite a while. And then our parents got old, and they had health care issues. Well, we knew how to do the system, and then we became their 24/7 caregivers, and we had to use these systems we're talking about in the nursing homes. And I need to give you an extra shout out to Camille, because previous legislative budget cuts took all the ombudsmans away from the state, and we had one for a while, one in Topeka. Well, our surviving parent is out in northwest Kansas, in Goodland. And the closest, at the time, before they got all the way cut down, they had the one in Hayes. And Hayes had to cover all of northwestern Kansas. It was crazy. And the complaints for my mother-in-law, were rampant, and there was nobody. They told me to figure it out. And time again, I had to figure it out. And through the course of that, we had to move her a few times because the quality issues in nursing homes, but in our case, she had supplemental Medicaid. So there are a few places that accept that. And so then you have to get the KDAD's report and see how many deficiencies these nursing homes cases. You don't want to send them to those low-level care, those ones that are cited. And you have to figure all this out. Ooh. But anyway, what she's talking about, that is dead on accurate. And I'm very encouraged to hear her say they're getting those reports and they're doing something, and it will be helpful. Please don't make any more budget cuts, and try to restore some money, because these are our folks, and it may soon be us. We're sure trying to stay home. But in my written notes, the issue that I wanted to bring up is, while we are in Morris County and we're not that far away from Topeka, we are miles apart when it comes to technology. And we cannot get sufficient signal strength, cell tower strength, connection, or training in all these wonderful technologies that are available and that are put to us. Well, we can connect you. You know, there's no doctor here that can take care of your condition, but we can get you on Telenet, and then you can't get the reception to go through. Or the staff, if they don't know how to make the connection, or it's not working today. Well, you know, and there was an episode that happened recently. My husband has been discovered to have some tachycardic problems, and a cardiologist happened to be coming to Council Grove, where we live, comes once a month, somebody from that office, and we had all these other tests we'd already done, and they said, well, you need to wear this monitor for 30 days, and it's no problem, it'll pick up signals anywhere. Well, he had an event, and he happened to be in Lawrence at the time, and the signal went through to the cardiologist that's in Topeka. Well, when we got home and he had another event, the signal didn't go through. And we're in Council Grove, which is about an hour away. But it took 6 hours for there to be enough tower strength for his tracing to get to the cardiologist's office. 6 hours? And that's not an exception, that's the rule. And when the COVID first started, and you know, you could always have plenty of strength, and I may not use the right words, but when the kids had to go online, boy, we couldn't get time on the system at all. You know, it was busy, and there was just a whole lot more people. And we have dead zones where we live, apparently, right outside of town, 3 miles out. Then there's this complete dead zone that goes on for another 20 miles. And when I call the provider for my cell phone, he told me, I asked to speak to somebody who could answer my questions about the towers. And they said, well, it sounds like you have a signal transmission problem where you live. And I said, well, what would be the answer to that? And, well, you need more towers out there. And I said, well, how do we go about that? He goes, well, I've looked up where you live, and it would not make financial sense for our company to put another tower up there. You don't have enough customers in your area. And why should I even have to know this? This should just work, you know, but it's not profitable. So I looked a little bit more into this, and what I'm told is that in Kansas, there is no regulation on companies that provide cell service. There's not a minimum amount of power signal that they have to meet, and there's no they just kind of do what they want. And in areas, if they don't want to come into your area, then the lesser, I don't want to say lesser quality, but that's what comes to mind, they come in, and it's not good. But by gosh, if you're willing to pay more per month, you're going to get more signal. Well, that, you know, for some of us, you know, we're kind of maxed out with what we can do, and then, oh, well, we'd get you better service if you'd pay more money. And that's really not the issue, because the problem is the signal's not getting there, and they don't want to put it out. The towers and even the fiber optics, where we used to live a few more miles west, they have old Southwestern Bell lines that AT&T never replaced. Although AT&T tells you they have fiber optics, they have old Southwestern Bell lines, and that's what they're using. And Southwestern Bell hasn't been an entity for about 45 or 50 years, and they're still using those lines. But they were supposed to change them, but they just haven't gotten to rural Kansas, which is my issue. Things are not getting to rural Kansas. And rural Kansas is, you know, 10 miles outside of Topeka. I'm sorry. And the rest of us are out there. And when you look at the statistics and you look at population, you think everybody's, you know, in Kansas City, Topeka, and Wichita. But if you look at the counties, those of us that are 65 and over, in Morris County, in just 5 more years, it's like 55% of our population is 65 and over. That's our county. But our county doesn't have that big of numbers. But we have important people. We're there. We want to stay there. We don't want to go to nursing homes. That's not an answer. It's not an answer for our mother-in-law. But there's no place for her to go. Now she's got dementia. And she's where she can be taken care of, and there's that. But she's clear out there, and we're here. And we're trying to manage that, and it's very difficult. And she doesn't understand what's going on with her dementia. I can tell her, and for 5 minutes, she's, okay, I get it, and then, that's gone. And so I look at her and I think, gosh, we don't want that for us. But it may be that if we keep cutting the budgets and we don't put services out where services are needed. And we to me, we have to quit looking at, oh, you can go to Topeka or you can go to Wichita. And no, you can't. So anyway, I get a little passionate. So, but I would like to ask that somehow we encourage the legislature to look at the broadband issue and the availability across the state, and not just, somebody's quick answer, but the reality of the availability, because when you need it, you need it. And it's like we found out this last month, we needed it immediately, and we didn't have it, and besides being upset, we were shocked. I mean, it didn't occur to us that this signal wouldn't go. We weren't that far away, and yet it didn't. And somebody said to me, well, you should have told the manufacturer of the thing. Well, okay, in hindsight, I guess so, but when you're having a racing heart and all this, and the idea was that there was just no signal getting through because of where we happened to be standing when it happened. I think that there's a way that the legislature could perhaps take a look at this and try to help it be more equitable across the board. And it doesn't feel equitable at all. We don't want to move, and we sure don't want to move into a nursing home, but we don't want to live in Topeka or Wichita or Kansas City. We like our area, and we think it can be better. We're going to need a little support and a lot less budget cuts to do it. So I think it's a quality of life issue and availability of services issue. And I think that this should be more equitable and more affordable in all areas of the state and not just the big cities. Thank you.
Thank you, Jan. So I'll draw your attention to written-only testimony from Sarah Hebert from Bethesda Home and Cecil Putterbaugh from Pioneer Lodge in Coldwater. So we'll take some questions now, if you have any, for either Jan or Camille. Questions? Representative Ousley.
Thank you, Madam Chair. So I guess to Camille, thank you for bringing all the people's voices to the committee room. And I'm sure you don't have all the answers, but I guess I'd just throw it out there. I mean, where do we go from here? Because this doesn't seem to be isolated in any one, home or any region of the state. This seems to be spread across wide, and I'm sure COVID, exacerbated existing situations. But
Well, I think some of the themes across there, thank you, by the way, for asking the question. Some of the themes across there were communication and support for staff, and I think education, training. So I know that, everyone wants to ask for more money, and they deserve that they need to be paid more money. I'm just frank about that. They're not paid enough. However, at the same time, there are only so many bodies to work anyway. There's still going to be staff shortages. We're hearing more people are going to be aging, and there's going to be less workforce for that population. So we're not going to have more money, probably, a lot to put around. So what we're going to have to do is some of the things we talked about, like the technology, and actually what she's speaking to. Do we have the ability with technology to do some of those things? So we need to look at some training and education for staff, being more person-centered, that we are talking to people and we are saying, look, you were assessed for this many hours, or you are assessed for a nursing home, or you can be in an assisted living, but what services do you really want and need? What do you really need? Do you really, instead of starting, we all tend to plug in services. So training the staff, having them understand that we need to be respectful and ask the person what they want, and that then we talk about with them, what do they really need? What are their own assets and abilities? What is, may I?
Yeah.
What is Ms. Kimbrell's assets and abilities? What does she really just need to continue to stay in her home? Or her mother-in-law, where she's at? What does she really need? And maybe we don't need more staff. Maybe we need staff that really just supply what people really need and listen to them to do that. So, but before they go there, the rebalancing, we're going to go back to another. So that's what I really think. We need to be assessing from a standpoint of what services do we have to offer you and piling those on people, to what do you really need? What are your skills and assets first? What are the relationships that you bring to the table that can help you as well? What technology can we use? What community supports are available that you can use? And then look at services. Then apply the services that where the gaps are, and just the gaps for that person, which means we have to know the person and assess that individually and apply that individually. And it's a culture change in our thinking. So there's some ways that we can go about that as a state that will help create that thinking process in that way for all of the entities that use that. And I would love to look more at that. One of those frameworks is Charting the Life course. It's across the nation. Many states are using it. And it's a change in perspective that we need to really make sure that we are looking at that way. That's a big global answer.
And Madam Chair, so as legislators, we hear about the lack of the infrastructure of broadband and the lack of access to it in several realms. You know, this committee's not unique in that aspect, but part of what you said about not having landlines in homes, you know, we still got 45-year-old Southwestern Bell infrastructure out there. Well, why can't we have a landline so that at least the residents in that facility can speak to, you know, their friends and neighbors, loved ones? That part doesn't seem to be an excuse.
It actually is a resident right regulation that they do supply private communication, the ability to do that. It's one of those rights that sometimes does not get honored.
I thank you both for being a part of the committee and in front of the committee. Thank you.
Senator Hildebrand.
Thank you, Madam Chair, and my questions are for you, Jan. Oh, you're welcome. Yeah, you piqued my interest on a couple of things that you had said. The first one was you kept mentioning budget cuts. Can you give us some detail on what budget cuts you are referring to? Because to my knowledge, unless something happened that I'm not aware of, everything was restored recently, or is there something else specifically you're talking about?
With the budget cuts to the ombudsman program, I know that a few years ago, when we were dealing with our mother-in-law out in western Kansas, there had been like 2 different ombudsmen that could look into situations for that community. And then the budget cuts, they could no longer keep those extra ombudsmen in place, and it got reduced. It was down to 1, the one based in Topeka. And now Camille has been telling us that you have 7? Is that what you said? Across it?
May I?
Yeah.
Yes, please.
We do currently have 7 regionals. We had received a funding. At one point, there were 9. And I think the agreement, and I'm doing this historically, it wasn't me, but I have read enough to know that historically there were 9. There was some extra funding given, and the program had promised that they would cover the veterans' homes as part of that promise. I'm going to have to guess, I'm being honest with you, I believe that stayed 2 or 3 years, and then there were some budget cuts that did take us back down to 7. Regional, be able to have 7 regionals. So that was probably what happened. Is I would imagine, even now we have two of those regionals are covering the entire half of the state, literally. But that is probably what happened in her case.
Thank you for that clarification. I thought you were talking about like nursing homes or something like that,
Well,
so. That
Yeah.
helps me. My second, that's probably more of a statement than a question. Broadband rurally is a issue. Not too long ago, there was I know Spark money, I think, if I remember right, $85 million was supposed to go to fund grants to rural broadband. And we have all this money coming from the federal agency or federal government to expand broadband into rural. It's almost, when you talk to people in rural communities, it doesn't seem like they're seeing it. So I wonder if it's something we might, as a committee, offer later as a recommendation, is maybe an audit on where broadband money for rural communities is that, make sure it's actually going to rural communities. So, but thank you for bringing that up.
Yeah, if I could just say, okay, in our area, I know that TCT got one of those grants some years ago, and when we moved in we were in the AT&T area, we moved into the TCT area, and one of the things that was tied to that grant that they got was that if you wanted internet service through TCT, you had to have a landline. And but to use their landline is 12 cents a minute if you talk on it. And if you have an incoming call, it's 10 cents a minute if someone calls you. And we have cell phones, my husband and I, and, we didn't want a landline, but we couldn't get internet. So now we have a $35 a month charge on our bill for this landline that only rings if TCT has to tell us something. And then they called one day and they said, "And what number are you at?" And I'm like, "I don't know. You called me. I don't know what the number is, but we don't have a choice." So there's an extra $35 on that bill to get this wonderful TCT internet that if I go outside very far, it doesn't reach, I'm into the next service zone and I'm on data. But just over in Dwight, you have to have a different internet service in Dwight for part of Dwight because it's divided by county. It's half Gary and half Morris, and it's just not consistent. The links are not consistent. The answers are not consistent. Go out over to Alta Vista, they're just having headache after headache over there, and nobody, we don't get a straight answer and a consistent answer. And for healthcare, we need consistent, we need to be able to count on it, and we don't. And I have a brother out in Mineola, which he's an instructor at Dodge City, and I think somebody was making a reference, maybe not in this group, but about the lack of service out at Ulysses, which is just, it's bad. And there's no reason for it in this day and age. We should all have a minimum equitable thing here that provides what we need. And then that's another issue to talk about, the training on how to use it. I mean, that's another big problem. But gosh, the signals have to be there, and they're not. It's not consistent. And I think the legislature can help this. I wish I could tell you how, but it needs to happen.
Thank you, Madam Chair, for allowing me one more comment. And you do bring up other good thoughts. The more technology changes and our world advances, this last census showed that everybody's moving to bigger cities. What's in bigger cities, bigger communities? Rural broadband, or broadband, not rural, it's urban broadband. But and with COVID, you have seen a lot of shift from a lot of even larger companies are allowing people to work from home. Well, if you don't have broadband access at home and you're in a rural community, where are you going to go? You're going to go to a community that has it. So rural broadband is becoming more and more necessary for rural communities. So
Yes, thank you.
I think that's another reason why we might want to make that recommendation. So
Yes.
thank you.
Thank you.
And I think I would like to echo Jan's comment about your issue with TCT and the phone line. I think that's a bit of a scam. We have that too, and we're paying for a landline that we don't want to use, so we don't put a phone in. But we have to have it in order to have the internet.
They've said it's because of the grant. Whether it is or not, I don't really know, but that's what they told us when we moved there. And they said, you have to have it. It's part of our grant when we got this.
So I'm wondering, you mentioned the Spark funding. Has that funding reached them yet? Who talked to us about that yesterday? Was that, Janice, was that you, or about the Spark funds?
The 10% FMAP bump for Medicaid. I don't
yeah.
think we talked Spark yesterday.
Somebody had a list of Spark funding that might have been
Scott talked about
Scott.
the Spark funding that
Okay.
we had received, but that was from the CARES money. That's not the current relief
Okay.
money. That was the CARES money that we got.
That's
Yes,
right,
so that
that's
was
right.
Spark from last summer.
Senator Hildebrand.
Yeah, Madam Chair, and if memory serves me right, the broadband was fairly early released into the Spark money. So it probably would have been last year.
I think it was
Or-
part of the CARES money also.
yeah, the CARES money.
That second tranche, there was a first tranche of federal relief, and then that second tranche was the CARES, and now we're in the third or fourth tranche. But I think the broadband was in the second tranche with CARES. Yep.
Did you? Haley has a
Thank you,
question.
Madam Chair. Yes, I too would echo exactly what you're saying, very rural north central Kansas. I would be curious to what they consider their criteria for service being provided, because having service and having reliable service are two extremely different things. So I would question that. One question that I did have, and this may be more appropriate for AAA, is the technology and internet services that are provided and where those gaps are. Is there financial assistance that pays for those services? I know there's like the technology waivers that help you obtain technology to begin with, but I'm talking for the ongoing costs and expenses. I know when we provided HCBS services, the challenge seems to be that a lot of these individuals are already on a very limited income to begin with. And then you might have, $100 bill to have a package that they require for phone to monitor your life alert, but then also internet to provide the monitoring, and also cable, is just kind of thrown in and bundled with it. And before you know it, you have someone living on a very limited income that now has to spend $100 a month to have another service provided. So I'm just curious if there's any resources that we know of that assist and aid in that.
Annette, would you like to respond to that?
So for the Lifeline, that is a service that can be paid for on a monthly basis for some of the individuals on Older Americans Act in-home services or the Senior Care Act in-home services program. But I'm not aware of any of the AAAs that are able to pay for monthly internet fees. I mean, sometimes there's some temporary kind of services or things like that. I know that there was some funding available, and I think they were helping people try to sign up for those that were income eligible. That was some federal relief that was available, although it was pretty, they either had to be on SNAP benefits or they had to be very, very low income. So a lot of the older adults we work with were kind of in the middle, and they weren't low income enough to qualify for that program that would pay for those internet services. But because of their expenses, they couldn't afford it on their own. So that is a big gap and a need for assistance with that monthly fee for internet access.
Madam Chair, if I may, I'm not exactly sure how to word that recommendation to the committee, but I believe that that is a major priority that we need to prioritize and look at as that unmet gap. It's great to have services out there, but if people can't afford them, it's pretty pointless.
Okay, we'll put broadband down just in general.
And one other question, if I may.
Go ahead.
Thank you. This is for Camille. I've grown up in long-term care. Of course, I'm always going to be an advocate for that arena, for healthcare, for long-term care settings. I have beautiful memories of that environment. And I know, you know, we can always find good and bad. There's both and in every situation. For every, you know, one negative, I could find you, along with my colleagues, multiple positives of people that say, this is my home, I love this place, this is my family. I'm wondering, are you aware of any positive places, positive nursing homes where you see that there are great things going, there's high employee satisfaction, high resident satisfaction, because I'm wanting to know what systems they have in place so that we can monitor and replicate that and put that in a form of education for our facilities in the state?
I would say that yes, and we did have some positive. I know it didn't, overwhelmingly was not necessarily positive, but we did have positive statements provided. And yes, we do believe there are. And I think that sometimes it's hard for individuals who have worked in a setting that don't see a lot of the kind of experience that you heard some of in those statements to imagine that that exists out there. As ombudsman, of course, we see lots of settings, and we see that wide array of situations. And so, yes, I think it's a really good idea to take settings where you have primarily happy individuals, and primarily it's a human service industry, so there's going to be problems in any of the buildings, but and that's just human nature. But overall that they are, and yes, we should take those and replicate that, and we should say, how is that doing well? And we can do that with the colleague here to my left, you know, with they do have some a wonderful campus, I think, and again, I'm not going to say anybody's perfect, and I'm not saying that you're not, but I'm just but I want to be clear that there are some wonderful things going on out there. Those are things that they can do because they may have funding to do that also makes a difference. However, I mentioned I did hear from an ombudsman in the region that was kind of saying it was a really, really nice visit at a particular place in a small community that does not have particularly a lot of funding. I think that I've actually had some conversations about maybe having that that individual, if they would come and speak to us about, you know, how did they do this? And I don't know the administrator personally. I don't, you know, there's no personal connection for here. But if you have that kind of, the residents are saying, I'm having a good experience here, when the ombudsman goes in and it's a relaxed atmosphere and the staff are not agency staff, they are staff that are from the community. They haven't had a lot of turnover. You probably have good leadership there that's helping with that too. And so all of the things being said, if that experience, if it feels good, it looks good, the residents are happy, the staff there are happy, yeah, we should hear from them. How are they doing that? Yes, thank you.
Lee, would you might like to make a comment?
I would like to help answer Haley if I could, and kind of touch on what Camille was saying. I've worked in nursing homes since 1996. I've worked in many different departments. Social work and administration has been my longest tenure. I've been in nursing homes from Salina to Kansas City working, so I've had a big, vast array of experience of good ones, bad ones, challenges, successes. And what I have experienced, we talk a lot about workforce challenges, and there's a huge workforce challenge in aides and in nurses, but I can tell you probably with great certainty from my experience, what is the mark of a home where you're going to have good experiences versus not is in that nursing management. The nurses that can be out on the floor to support, and that it's consistent. I can probably guarantee you a lot of the homes that have bad outcomes or a lot of challenges, you're going to see a lot of turnover in the management and leadership arena. And so I don't know if that's a recommendation or how you work on that for workforce issues, but as an administrator, when we have a solid leadership team that can help support the aides, that can help support the nurses, that can just be out there listening to the residents and what they need, that it's going to go better. And so I don't know, but if that's how I would answer your question, Haley, is in my experience, it's the consistency of the leadership.
Yes, Camille.
I have to echo and agree, and I think a lot of that comes from who owns and hires that leadership, and what do they want out of that leadership. And I would say that one of the things that I would hope that the legislature period would look at too is if we have an opportunity to take a look at ownership issues with nursing homes, and that what I have said from the beginning, we've seen for several years now, it's becoming worse and worse. It's not just Kansas, but it's our job in Kansas to look at it is that we are able to hold the ownership of nursing homes accountable. Right now, most of it is targeted at the nurses or the licensed administrators, which we don't want to, that needs to be in place to merit the public trust. But we need to be able to hold those corporations accountable, because what happens is administration or management is getting caught in between that owner that's setting in another state, making policies that are not they're outside of regulation. And then the person is like, what do I do? Do I do the right thing by this person that I'm serving and possibly lose my job? Or do I make the owner happy? And so that's, I think, a theme we might sometimes see as well, is that ownership that's supporting or not supporting the management in the building. That's, yeah.
Okay,
Sure.
good. Good.
Bill
Yeah.
Persinger, Topeka. Oh, I'm sorry.
Yeah, I've got two ahead of you. I'll get you on the list, though. Thank you, Bill. Let's see, I've got Deborah Zier next.
Yes, thank you. As Camille was sharing the litany of complaints that she has from those few residents and family members, it put an exclamation mark on the issue of staffing for me. We are in the middle of a staffing emergency in long-term care, and if we don't get a grip on it, long-term care services as we know it is going to collapse. And so there are a number of factors there. I know this task force has been talking about workforce. A point I would bring up is temporary staffing agencies. We need to have regulatory oversight. It's the Wild West. There's no registry even. If you ask KDADs who all the staffing agencies are in the state, they couldn't tell you. There are no minimum regulatory requirements, so there are contracts that are signed, but they sometimes are not adhered to. And so that's a big issue. That's a big financial drain for the state when you have to pay 3 to 4 times as much for temporary staffing as you do for good, solid, stable staffing. So there are issues there that this task force should be cognizant of. The other thing on the food issue, I find that very disconcerting that there may be some nursing homes that are not able to provide adequate nutrition for their residents. I think nursing homes, like a lot of other places, are really suffering under the supply chain problems that we're experiencing. Particularly in rural areas, there are some rural areas, some rural adult care homes where their typical provider of food says we can't do it anymore. So that's a dilemma there. Another indication of is this system sustainable? Frankly, the other thing I thought I would just mention to the task force is for several years now, KDADS has collected and published resident satisfaction survey data. So if this task force would like to hear overall resident satisfaction, that might be something you'd want to report on. Because it's been in place, it's kind of been flying under the radar now for a lot of years, frankly, but it's there. And when they first set it up, I'm not sure how it's going now, but they would have third-party objective people come in and do those surveys in some instances. So that would help frame a context for some of this information you're getting about poor performing providers and resident satisfaction. The other thing I'd point out, and many of you know about the PEAK program, again, longstanding in our state, promoting person-centered care in nursing homes with resident satisfaction high in those homes typically. And so you all might want to learn more about the PEAK program because they do concentrate on quality of life for residents in nursing homes. You could learn, we could hear a lot about that from those. The K-State actually administers the training and support for that program. Thank you.
Thank you. For a response, we'll call on Janice.
Deborah, real quick, this is Janice DeBoer, Deputy Secretary of Programs at KDEDS. The resident survey, I think, Madam Chair, that was a volunteer opportunity for those nursing facilities who wanted to engage with a contractor that we had brought in to help us just get some good feedback from consumers regarding the program. I think, Deborah, the last 2 years with COVID, I'm not sure if we extended that contract. I don't think we did. You didn't have one okay, Haley didn't either. So I'm not sure that that is still an ongoing opportunity, Madam Chair and members of the task force, but we do have information from the past survey results from the organization we worked with. And then I would agree with Deborah on PEAK. It might be that you want to bring in some folks from K-State to talk about the PEAK initiative. PEAK has been around for, well, I think Connie Hubble, when she was secretary, brought in the PEAK process. It has transformed itself over the years. It's a little different now than it was in the beginning, but it might be something, Madam Chair, you want to bring some folks in from K-State, and we could get you those contacts, just to talk about the PEAK program and how it attempts to incentivize facilities and reward them through our reimbursement mechanism.
Thank you. Thanks for that. Okay, next question I have is Linda Mowbray on WebEx.
Thank you, Madam Chair. Linda Mowbray, Kansas Healthcare Association. I have two comments for you. The first I'll make is on the satisfaction survey that Deborah Zaire was speaking of. That was a voluntary program, yes, but the reports that were to come out of that were to be made public and also have a footnote of those facilities who chose not to participate. So as a bit of a shaming mechanism, if you will, if the individual said no, they were not going to participate. A long time ago when this started, the idea was to be able to rate the facility using sunflowers, similar to the five-star system. That really never did come to pass, but the information itself, it's very good information, and a lot of it revolves around a core queue, a core number of questions, including would you recommend this facility to a family member? And that's kind of at the heart of how satisfied are you with the care that's going on. The original comment that I did want to make, though, was back to the broadband issue and the issue that Haley brought up as far as individuals with a very limited income having to purchase those expensive packages. Kansas Healthcare and others have been talking with the MCOs as upcoming changes or things may present opportunities. That there's not a lot of value add in the MCO programs for folks that are in nursing homes or on HCBS in assisted living. And the access to technology, the cell phones, the iPads, the internet connection and whatnot would be an incredible value add to those individuals who are on very limited income and are being asked to make choices about how they spend their leftover $62 or less if they're in assisted living. So those are my comments for you.
Okay, thank you. Next, I have Bill.
Thank you, Chairman. Bill Persinger, Topeka with Vallejo Behavioral Health Care. I just real quickly want to think out loud about broadband and connectivity in general, particularly as it concerns healthcare. And as we develop our recommendations, I wonder if a large topic area could be public safety. This could be a matter of public safety. That phrase alone gets people's attention. I live in a rural area and have to have a hotspot to watch Netflix. So it's a horrible problem to have. But on a serious note, if I needed that kind of healthcare support, you know, and I just live a few miles south of Topeka, by the way, but if I needed that kind of internet for healthcare support for a heart monitor or other kind of, you know, and it's my choice to live there. But some people can't make that choice. They just can't make that choice to move to a city. So I just wonder if we ought to have a large area called public safety. It might get more attention than I need broadband because I live in a rural area. Because, you know, sometimes the reaction is, well, just move. But, and that's harsh and not possible for people, obviously. So maybe public safety is our issue, just like our roads and other forms of the way we move people and information around. Thank you, Chairman.
Thank you. I do think that broadband's a hot topic, I would say, in the legislature right now, but point taken. Other question? Oh, Representative Ousley.
Thank you, Madam Chair, and thank you, Bill, for the thinking out loud comment. I serve on another committee that is Kansas Securities Committee, and I think it's been 2 or 3 years ago we started discussing FirstNet, and FirstNet is first high-speed nationwide wireless broadband network dedicated to public safety. And it's being built by AT&T, and it's supposed to be spreading across the nation. And as it says, it's supposed to be for first responders so that they have, you know, that access for public safety. But if I recall discussions correctly, whatever was left over could be utilized otherwise. You know, that it wasn't going to be fully consumed by first responders, though its sole purpose was first responders. I don't know where we find out more information where that's at, or if my recollection is accurate, but I don't know if that's something maybe staff could help us with, that if that's even relevant to this conversation. But while we were thinking out loud, I've been reminded. Thank you, Madam Chair.
The remaining bandwidth would be, yeah.
Yeah, and the frustrating thing is that the technology that we had, was working for us. That, and I'm thinking specifically with Jan's situation. You know, once upon a time, you wore the heart monitor, and there was a little credit card that you held up to a phone and sent those signals into the doctor's office, and that worked, and that was amazing. But they don't do it that way. It's moved forward, but then the rest of the area doesn't have the technology to move forward with it. So, Representative Ousley.
Just to comment on that, which I think really displays that broadband and broadband access should be a public utility and not something otherwise.
Thank you. Deborah Zier, is your hand still up, or do you have a new comment?
I have just one little informational comment. I did a quick survey of about 15 of my members on the landline question that Camille brought forward, and everyone who responded said that they do have landlines available for residents. However, they almost all to a person said residents typically bring their own cell phones. So, but they're willing to set those up and so forth. So it's a representative sample of about 15 nonprofit nursing homes. Thank you.
Haley.
Yeah, to add to that, I could use my facility as an example. A lot of us in Kansas rural are your 1960 buildings, stucco, cinder block concrete, and we ran into that exact situation. We had the landlines. people come in with cell phones, you get zero reception. So we have had to put Wi-Fi boosters to try and create mobile hotspots for people to use Wi-Fi calling. That is if their technology can sustain that. So for every answer, there's another problem.
Yeah, Representative Ousley said, welcome to our world. Okay, are there other questions? I'm not seeing any more online either. Okay. All right, we will move on to the next area. Thank you for that discussion. That was good. Next up, we have a presentation on the survey process, deficiency levels, and fines. Do we have Lacey Hunter here yet? No, there she is. So this is Lacey Hunter, Commissioner of Survey Certification and Credentialing with KDADS. Welcome.
Thank you, Madam Chair. Thank you, committee. All right, well, I brought a few backup things in case there's some questions, because we do have a little spare time for some more questions before lunch with me, so I will get started here. This first couple of slides is just a little bit more about the internal structure of SCC as far as what we have available to us for surveying and that survey work. So this first one here kind of talks about our administrative staff that you have up here at the Topeka or central office. A lot of times you hear providers talk about the folks up in Topeka. Those would be the folks that they're typically talking about right there. And then, as you go up the food chain there a little bit. We do also have our nursing facilities are split into 4 regions throughout the states. So we typically have 4 regional managers. We did have one who retired here recently. So we had someone step in and then we had another person who resigned. So we have someone who is doing interim in 2 regions right now. And then we have a couple of regions, it's not listed here, but where they don't have necessarily that QI person because the QI is doing that regional manager role, it's in that southeast region right there. And then the other information I put there was our abuse, neglect, and exploitation hotline information. KDADS is responsible for running that hotline for all nursing facilities, but it's also all medical care facilities. Next slide, please. This next slide kind of depicts the 4 regions that I discussed there, and then it gives a little bit more information about how Kansas looks as far as adult care homes and what we have as far as the state agency to provide the services that are required of us per statute for those adult care homes. So currently there is somewhere in the ballpark around 326 nursing facilities, 3 adult daycares, 2 boarding care homes, 128 assisted living facilities, 176 home plus facilities, 49 residential health care, and then 101 facilities that are attached to a nursing facility. That means that the facility's license is priority is the nursing facility bed, so it is classified as that, but then they also have additional adult care beds listed under one of those categories. So as far as staff goes, right now we currently have separate staff that survey the adult care homes for state license only versus the federally certified nursing facilities. The federal survey process is quite different and dictated mainly by CMS, so there is a bit of a split in that staff pool as well, so that those staff can focus on their main area for survey. For the state licensed only, so for all of those numbers I just listed out there besides the 326, we have 7 FTEs of that right now. This has actually been changed since this slide was made. We now have 4 state licensed only staff and 3 vacancies, but 7 total FTEs. And then as far as the federal staff is, we have 37 certified federal surveyor staff, and that vacancy list has actually gone up a little bit too. We're somewhere in the ballpark of 22 now. One of the issues that we have is kind of depicted here in that next outline, which is that the average salary for our survey staff is around $53,000 a year, and those staff are registered nurses. And I think many of you can attest to registered nurses being having opportunities to make much more than that right now. So we struggle with finding that RN staff as well. And then the other thing we have on there is that the average size home in Kansas, when you kind of look across the board, is 62 beds. So that's a decent sized building when you're kind of looking at it comparatively. But that goes from having homes that do have somewhere between 1 to 2 residents all the way up to those several hundred buildings. And we have buildings both in skilled nursing and in assisted living that reach over that 100 bed mark. Next slide, please. This slide goes over kind of a little bit of the work that we've been able to accomplish this year. This is probably my brag slide about my staff and what we've been able to accomplish here with the staff that we have that I just showed you. We are still able to get quite a bit done. So far for Q1 and Q2 of this year, 102 surveys completed, and since the beginning of this year, we've had at most 5 surveyors in that area. So that's quite a bit of work for those gals to get done. And then on the other side, 109 surveys for the nursing facility side. That survey process, as you'll see in my next couple of slides, is a bit different and a bit more lengthy. So that's where you kind of see that difference between the number of staff versus the number of surveys and work getting completed there. I'll just go on to the next slide. The rest of the information is good information, but you guys can read that at your leisure. So I'm going to get started on the survey process. I wanted to kind of make this as focused as I could. So what I did was I have in my presentation here outlined the long-term care survey process, which is a survey process that is depicted by CMS. But what I'm going to do is kind of just then walk you through these slides where you would then maybe see a difference in the survey process for a state licensed only home who's not necessarily going through this entire long-term care survey process. So the first thing that you kind of want to, I think, get a little bit of an understanding about is when we switch to the long-term care survey process. So CMS used to have what they called the traditional process, and they had also what they had called QIS. And they took those two processes, mixed them together, and created what is called now the long-term care survey process. That process started in 2017. For us as a state, the process wasn't nearly as hard to integrate into because we had already computerized our system in that QIS process, and we're kind of a guinea pig state, so to speak, for the long-term care survey process. So it wasn't much of a transition for us in 2017 to get to this process that CMS has done. But for several reasons, CMS implemented this process. I think one of the bigger reasons was to have consistency across each state and have consistency in the survey process for any Medicare, Medicaid provider. Next slide, please. So on this slide, I have a little bit of information on when your building or when a building is going through the long-term care survey process, kind of some of the important things that you'll want to make sure that residents are aware of and that staff are aware of, and things that we kind of, we try to educate our staff on to make sure that they're also, when they're talking with residents, when they're talking with staff, that they have kind of been explained what the expectation is and kind of what the conversation would look like so that no one feels uncomfortable during that conversation or during that interview. Next slide. All right, so then we get into day one. So day one of the long-term care survey process, I have it kind of put out in boxes for you here. So when our surveyors walk in, this is kind of what you'd expect on that first day here. And so one of the bigger things that we try to do right away, because our visits are unannounced. So one of the things we do and try to get into right away is some of those key observations, because those observations might change once the word gets spread that KDADS is in the building or the sunflowers are blooming or whatever the key code is for that home. There's codes. Haley knows there's codes. But so some of those things are tours of the kitchen, watching a meal, watching and doing those resident interviews, doing those staff interviews, kind of getting some of those initial observations done. Because one of the things that then leads you into day two, if you want to go to the next slide, is you then kind of get into meeting back with your team and completing what's called kind of that initial pool process. And that's basically taking all of your quick observations and all of the information that you gathered from day one inputting it into the computer system, and then seeing where that computer system then leads you down and what pathways are being triggered for the rest of your survey process. That process is all automated. It's based off of the information you put in, so the information that we put in is very critical. We do and pride our staff on being always up to date with the CMS training. I did look for a figure, and it's not as great as I thought it would be. It's at 82% out of 100% compliance with training, but one of those things is that they don't recognize when staff leave throughout the year, so there's that. But anyway, so you go into day 2, and so day 2, you kind of continue on, but you really kind of start to get more detailed in that survey process. So you continue with those observations, you continue with those interviews, but then you also get into looking into records, looking into the electronic health record, looking into someone's negotiated service agreement, looking into the staff records to see if staff have had their TB test or if they've had their background check, those types of things. And then if you want to head on into the next slide. So the rest of the survey process is basically kind of just continuing on with what has been triggered as you continue to input information into your computer system. I think the biggest difference that in all of what we've discussed from day 1 to the remainder of the survey between a nursing facility and a smaller adult care home that's maybe state licensed only, such as a Home Plus, is that all of that could happen in day 1. When you go to, say, a Home Plus, that is 6 residents. You combine basically all of that into just day 1, and you are in and out all in one day. So that's the biggest difference. And then if you want to go into the next slide, once we have completed all of our survey work, by statute, we give an exit conference. And that exit conference basically kind of gives us the ability to open that communication line. If it hasn't already, it should be. But if not, reestablish that communication line between the facility on kind of what we saw, what we're expecting to cite. We don't necessarily always tell them the scope and severity unless it's of an immediate jeopardy. If it's immediate jeopardy, we do let them know that that's the scope and severity, and then at that point go into an immediate jeopardy template. But that is a bit of kind of how you can expect the survey process to go. On this slide, the other big difference I think that you'll see between the nursing facility surveys and a state licensed only is that when we do that exit conference, it's not always the nursing home administrator. It could be that operator, and it's not necessarily always a DON. And the resident council, the participation is not required like it is in a nursing facility. Resident council is just required that we ask, and that the facility at a state license only provide the ability for the facility to create a resident council, but it doesn't request or require that resident council be there at that exit meeting like it does for a nursing facility. Next slide. So the next one kind of goes over just a few things that if you're not familiar with the long-term care survey process or the survey process in general that you may not know. And one of those things is when we go in, how far back do we look? How far back are we going to dig in your records? How long do you have to keep your records? Those types of things. So that is called the look-back period. The look-back period is different for a CMS nursing facility versus a state-licensed only facility. A state-licensed only facility, the look-back period goes back to the last on-site investigation completed at your facility. Excluding if we did it when we did your infection control survey. That infection control survey does not count. But then for a certified nursing facility, the look-back period CMS has dictated to be any time between now and the last annual survey. And for us right now, the average amount of months between those standard surveys is about 17.6 months. So that look-back period is on average about 17.6 months, so to speak. The COVID criteria, when we're talking about doing those infection control surveys and doing COVID surveys, we were recently given an update from CMS that those are no longer mandated. We used to have what was called the 3 to 5 day survey list, which was a list that we would get on Wednesday for the following week, and we had to complete those surveys within 3 to 5 days. Those surveys have, the requirement for those surveys has went away. We do still get the information on what facilities are being heavily impacted by an outbreak or by COVID, but we're not required to do those within 3 to 5 days as we were previously. That survey process has been embedded into the infection control portion of the long-term care survey process. So when we are doing one of those annual surveys, that COVID portion of the infection control portion of the survey is still being looked at. There is a little bit of always kind of a question on how many surveyors go out on a survey. In state licensed only homes, it's 1 surveyor. We only have 4 right now, so those gals are on their own and one at a time going into the buildings. The survey size for a nursing facility is dictated by CMS, and it's based off of the resident census. Typically, there's a minimum of 3 surveyors, especially if we know that there's COVID in the building, because we will, once one of our surveyors has entered that red zone, they no longer resume survey activity outside of that red zone, typically, if we can afford to have the staff to do that. The other thing that kind of changes the survey process and can lengthen the survey process quite a bit, especially right now, is the number of complaint allegations that we attach to a survey. So when we're going out and doing a standard survey or an annual survey, we have the option to attach complaint allegations that have been called in or that we have received. And depending on the number of complaint allegations, the federal survey guide requires that we up the number of surveyors on a survey depending on the number of complaints we attach to that. There's not necessarily, right now, CMS does not have a maximum number. They're being pretty lenient because there is a very large backlog of complaints in most states given the limited activity that they did give to us in 2020. But all of the process and all of the guides can be found on that link there at the bottom then. Next slide. All right, so then after the survey. It doesn't stop there. That's kind of where our surveyors stop. That's kind of where, if our boots on the ground surveyors in the building, that's kind of where their knowledge stops of the survey process, because that's kind of where their responsibility stops. But then you move on into kind of more of those central office roles where you have those regional managers and QIs reviewing the citations. But for what you can kind of expect as far as what CMS outlines and what we kind of dictate in policy is that within 10 days, and that's business days, we have provided you with a statement of deficiencies, which is a form that is a federal form that we also use on the state side that outlines any deficient practice that we would be citing your facility for and the scope and severity at which we were citing that facility or that deficient practice. Once you receive that statement of deficiencies, there's another 10-day timeline for what's called an IDR, which is an informal dispute resolution that gives the facility an opportunity to dispute any of the citations that were written. And then also within 10 days, the facility and a nursing facility is required to provide us a plan of correction for any citations that were cited. A state license only facility does not provide us a plan of correction unless we issue a correction order based off of the deficient practices that were cited and the level of scope and severity in which those deficient practices were cited. Next slide. So this next one, I did a little bit of information about what surveyors are looking for dementia, the dementia process, and when you have residents who have dementia. There is some specific training that our survey staff have to do, and there's also state regulation and state statute as well as federal statute that requires facilities to provide their staff with dementia training if they are going to be providing care to dementia residents. So this is some of kind of the stuff that we ask and are looking for on survey to see if those regulatory standards have been met. Next slide. Okay, so next I did a little bit on if we are only doing what we call an abbreviated or a complaint investigation. And so in those, again, that's kind of where you get to one of the main differences is probably the number of people that are going and the amount of days being spent in your building. Both of those, again, are kind of dictated on the number of complaints that you would be investigating on that federal side. On the state license only side, again, you're looking at one surveyor regardless of how many complaints you're looking into. But this, again, kind of gives you a little bit of a touch. I did leave tour of the kitchen in there. I don't know that it necessarily has to be because we would only be looking at the kitchen if the complaints alleged an issue with the kitchen. So I do apologize for that error. Next slide. And then this one, again, is very, very similar to an exit conference for an annual survey, but I did put it in here because there are just a few different things that are, when we do a complaint survey, it is just basically a shortened process. It's a shortened survey, so it's a shortened process, but I went ahead and put that in there, but I don't want to repeat myself, so I'll go ahead and go on to the next slide. So then we kind of switch in my presentation over to the CMP portion. There were some questions about civil monetary penalties and what happens, how they're issued, what happens with that. So this first one I put up here is about a state licensed only and kind of what our state statutes talk about as far as CMPs, how much we're allowed to assign for a CMP, and then where that money goes once a facility has paid for those CMPs. The CMP amount for the state license only is much, much smaller than the scale that you'll see for CMS. And if we go into the next slide, I believe we get into, yes, the federal stuff, where you can see we as the state survey agency, we do enforcement on nursing facilities on behalf of the surveys that we do, but we are restricted to only providing Category 1 remedies. And a CMP is a Category 2 remedy that is only allowed to be given by the regional office. So the state of Kansas or myself or my staff are not allowed to assign the federal CMPs. But where you can see over on that right-hand side is where you can see how those CMPs get much greater in price than what we are capped at here at the state level. Many CMPs reach several $75,000 plus when you're looking at that federal side. The next slide talks a little bit about the CMP reinvestment program. So CMS has come up with this reinvestment program, which allows for when a CMP is assessed for a nursing facility in your state, a portion of those funds are then given back to the state of Kansas to put into the CMP reinvestment program. We use that fund to provide any nursing facility programs that have entered an application to use CMP funds. CMS has a pretty good program and has outlined greatly what can and what cannot be acceptable for CMP funds. We do tend to keep a portion of the CMP funds backed and reserved in case there are receiverships or things where we need to step in and utilize those funds to help take care of residents found in those settings as well. And down there, you'll see that current balance of the fund. And our fund right now is a little over what we like to keep in reserve for that receivership. So we do have a little bit of money. So we do have a program or two we could be reviewing and retaining. And I think that we are well in that process of reviewing a program. And then on the next slide, you'll see a couple of programs that, did we skip one? Yeah. On this, these are the two programs that we approved and granted funds for in 2020 for this CMP reinvestment program that I discussed. And then on the final slide, you will see the money that we provided during COVID. Both of these opportunities for the nursing facilities are still available. The availability for state license only has closed. But what this is the federal government created a program for states to use CMP dollars to provide technology devices as well as visitation devices to homes. We were able to figure out a way to come up with funds to mimic that on the state licensed only side. And here you'll see kind of those numbers as they sit for what we have produced and provided based off of those applications we received. That is it for me.
Thank you for your presentation. Sorry, you talk fast. I was trying to catch up with you with where you were at. I want to go back to the page where you're talking about, page 18, where you're talking about the monetary penalties. Yeah. So I'm trying to read this well. So you collect the penalties and then they're sent to CMS and then some comes back. Okay.
You got most of it right. The penalty is collected by CMS and then they distribute a portion of that back to us based off of basically how the census for that building is split on the number of residents that are Medicare or Medicaid versus private pay is kind of how the split then goes.
Okay, and then I've kind of followed this for a few years. The fund is kept for the potential emergency receiverships. So can you explain how that's used? I mean, do you use it to manage a home that is essentially abandoned or take it over?
In 2017, that's exactly kind of how that money was used. We had 15 facilities just in our state alone, but it was a nationwide thing. But in our state, we had 15 facilities where the owner of the facility basically just wiped their hands clean of any of what they thought to be their obligations for anyone living there or their obligations to any of the agencies that they respond to. So we then used that money to hire some people to come in and help us run those homes. And so a large portion of that money was given to management companies to run the physical day-to-day activities of those homes while those residents were living there.
So during that time when there were so many, was that fund depleted?
It went up and down because Janice, you might have to correct me here, but I believe all of the funds that were used or given to a building for receivership purposes have been restored. And they were restored as they could be, so that it has balanced up and down. But as funds had enough to pay us back some, they would pay us proportionally for what they could afford based off of kind of the projections for that home.
Okay. Did you want to respond,
I might just
Janice?
say, Madam Chair, the fund wasn't depleted, at least not that I recall. Brad Ridley has never indicated that we completely depleted the fund because, as Lacey said, keep in mind that when a building's in receivership, we are continuing to bill Medicaid and Medicare. So the revenue streams continue to come in to support the operations in general. What happens at a closing then is we attempt to get all of our management fees back and recover that we possibly can at the time of sale. So basically, we get back what we have put in as a general rule, but we do still need to keep that balance and I think Brad reported last we had 3.5 to 4 million or so in that fund. So it's not a lot of money, but it's enough that if we need to move fast, we've got that fee fund we just tap into. So.
Okay. And are all of those 17 sold now?
There's still one that's on the market, but the rest have been sold.
The 15 Lacey's referring to is Skyline, and those 15 were all sold to Mission Health. And then we had actually a total of 22 when we came into the agency in 2019. There were 22 homes in receivership. We have sold all of those buildings, including the 15, except for one. So Providence Care Center here in Topeka, we still have under receivership.
Okay. Well, good job with getting them sold. Do we have questions for Lacey? Representative Ousley.
Thank you, Madam Chair, and thank you, Lacey, for being here. Page 16, you says this can double if the facility has been cited for non-compliance within the last 18 months. Is that a rare occurrence?
I think the accurate response would be depends on the home. For some homes, it's a pretty common occurrence for them to be cited within 18 months of each other. For other homes, they pretty regularly have deficiency-free surveys. You have kind of your bad players, but then you also have your good players. It just kind of unfortunately depends on the home and what they're willing to put into it to see what they can get out of it.
This is my first overview of this in that I can recall. Because that would raise a question to me, is our civil monetary penalties, are they accurate? Or should they be updated? Are they at a satisfactory level to be consequential or accountable, but not so punitive that we're going to shut them down?
I think I could do some more looking because one of the things we have available and we can kind of see on the state side is of the monetary penalties that we've issued, who's asked for a payment plan, and that might be kind of a good indicator of whether or not those amounts are what kind of financial strengths they're putting on a facility. But I do think you're accurate in that there's kind of a balance of making sure that amount is high enough to know that they did something wrong and that we mean business, but not high enough that it's going to put them out of business and displace people from their home.
Go completely against the mission,
Right.
not what we want at all. But for non-legislative members on the committee, oftentimes in the legislature, you hear, what are other states doing? Does this, meld with what surrounding states, is it comparable? So that's the only reason I ask. But thank you, Madam Chair. Thank you, Lacey.
Margaret Farley has a question.
Thank you, Madam Chair. Margaret Farley with Kansas Advocates for Better Care. I may have missed it, but did you talk about the process for when penalties are imposed and facilities are able then to have informal dispute resolution around that? Could you go over that process?
Certainly. So once a facility has been cited a civil monetary penalty in the CMS world from CMS, CMS is required to afford that facility the right to what's called an IIDR, which is an independent informal dispute resolution. And the assignment of a CMP is the triggering event to afford a facility that right. But it is at that point, there's a few more who can participate as far as on the panel. For the IIDR, there's a few more restrictions, but it is kind of the same process as far as reviewing any deficiencies that the facility wants to dispute.
And is there any anything positive or negative for facilities once that informal dispute resolution is completed and they have CMPs? And I'm talking about CMS process.
Sure. So when an IDR happens, or an IIDR, if the citation that the facility is requesting to be disputed is at an F or below, which would be A, B, C, D, E, F. So F or below, as long as that F is not substandard, the only outcomes that can come from the panel is that the deficiency is deleted in its entirety or the deficiency is upheld in its entirety. If the deficiency is of harm level or above, so G or above, there is one more outcome that can come into play, which is that the scope and severity of that deficient practice can be lowered. If the outcome is that it's deleted or lowered, then whatever it is lowered to or deleted from, the enforcement actions that were triggered due to its original state are then removed. So you then kind of backpedal anything that was triggered because of such a high scope and severity or because of an allegation, and those get removed if the IDR process it concludes with one of those two outcomes.
Thank you. May I have one more? You were talking about the two situations where either the complaint or the citation is founded or not. And if it's not, that stops any further public information about that particular event because it's not cited as a deficiency. Is that true?
So when an allegation is entered and we go out and do an investigation, the things that become public knowledge at the end of the investigation would be the outcomes, which would be whether there were an outcome or not. If there are no outcomes, it's still stated on that statement of deficiencies form, that 2567 form, but it just states that that the facility was found to be in substantial compliance at the time of the survey. If it is a complaint allegation in which the person who entered the complaint or the complainant, if they would like to know the outcome, they are then sent the outcome of their complaint investigation that they reported. But that's kind of does that answer your question?
Well, sort of, but yes, thank you.
Okay.
Yeah. May I have one more? So the frustration that KBC hears from people who make complaints is that they often don't have anyone from the survey agency that has called them to find out more details about what the complaint was. The other thing they complain about is they say if the surveyors are in the building on, for example, a complaint survey, that they are not cited unless the surveyor can find evidence of that violation on that day. Are these myths or is there something to that?
When we go out and do a survey, we will be surveying for any of the information that we can find. And if it's a complaint investigation, we'll be narrowing our survey to just those areas in which the alleged complaint issue is. We don't always or are not always able to get a hold of the complainant. And sometimes the other thing is that the complainant is an optional information piece to give. You are allowed to remain completely anonymous when you report to our hotline. But then the other thing that we have an issue with a lot of times is if they have maybe recorded something or taken a picture of something, a lot of times that information is not date stamped. So it makes it hard for us to include that in our investigation. But when we do an investigation, we are investigating and doing a look back period from the day we entered the building through the last standard or annual survey. We have the ability to look through and go back as far as that period. CMS does not allow us to look further back than the last annual or standard survey for any investigation.
Thank you. Thank you, Madam Chair.
I've got a question from Annette.
Hi, thank you for your presentation today. I have 3 questions for you. Are you seeing a trend? On page 3, you list the number of nursing facilities. Are you seeing a trend in a decrease in the number of nursing facilities in Kansas?
We have seen a few homes that have chosen to close. I don't have specific numbers on me, and I can certainly get that for the committee. I do think it is maybe a few more than you would see in the average year, but it is not an alarming number of homes at this point, no.
Okay.
Madam Chair, may I add?
Yes, Janice.
Annette, if you don't mind, however, I might just note we've seen census in the number of buildings as low as we've probably ever seen in years. So it's not that the buildings themselves are closing yet anyway, but the number of residents in the buildings is as low as I think we've seen in years.
Next question, I have Bill.
Oh, I've got 2 more. Sorry.
Annette, I'm sorry.
That's okay. You also on that page reference the number of multiple types of facilities. Do you have a map of where those facilities are?
We do not. I believe there is some people within KDADS who just got the technology to do some mapping stuff and the software to do mapping, but it has not made its way to my commission yet. So no, we do not have a map of those services. We do have a directory that is publicly available that you can go out and narrow down by county. And then that does provide you the types of beds, who owns the facility, and then a history of any deficiency reports and plans of corrections that that facility has submitted.
For all those types of facilities?
Yes, ma'am.
Okay. And my final question is referenced on page 13, where it's about dementia care. Mm-hmm. Is there a standard dementia training that is required, or is it just dementia training in general?
There are some standards that they allow or cite, but there is no specific structure to the dementia training that is provided. The facility is just required to provide that training. And then when it comes to the training for our survey staff follow any of the required training for when we would cite that tag.
Is that an annual training requirement?
For facility staff, I believe so, but I will have to double check. I would know off the top of my head. Camille, do you? It is? Okay. Okay.
Thank you.
Yes.
Okay, now Bill.
Thank you, Madam Chair. Bill Persinger, Topeka, Vallejo Behavioral Health Care. Or just to anybody in the audience, but maybe more to our KDADS officials, are there any within long-term care facilities, any pay for performance pilots or provisions? Like if a facility achieved a certain benchmark, would there be, extra pay, bonuses or year-end reconciliations of any kind? I'm seeing some heads go up and down over there. I just had an idea about, a couple things.
When it gets into how homes are reimbursed for their services, you're getting outside of my arena. I'm sorry.
Thank you. Maybe I should have directed that to Secretary.
Yeah, we'll look to Secretary DeBoer.
Yeah, so just FYI, I think Deborah Zare mentioned it earlier, and Haley might also, about the peak process. So it is,
Oh, that's right.
honestly, Haley, I forget what peak stands for these days, practicing with it?
Performance.
Okay.
Promoting excellent alternatives in Kansas.
Okay, so its genesis was all about encouraging nursing facilities to move toward more person-centered care, but now that is the norm. Person-centered care is now expected by CMS, but we still have this peak incentive that does reward facilities for Bill essentially doing what you were just talking about, which is, and Haley, you all can, it recognizes those buildings that provide more than you might just expect. And you all can probably explain it better than I can. But yes, so we do have an incentive. And Bill, what we do, we actually link it to the per diem reimbursement rate. So in the old days, it was just, we recognized buildings, we went out and gave them plaques, we said thank you. But over the years, we did start linking that peak initiative and that incentive to our per diem rates.
Haley,
I have a follow-up
Wait.
too, Chair.
I think Haley wants to respond to that.
Sure.
Thing.
Yeah, I would just add kind of comments onto that. There's multiple different targeted goals and targeted areas that you can incentivize. And if I remember correctly, I want to say like the max that if you, there's foundation levels, like you have to build upon everything. And at the peak of it, pun intended there, I want to say it's about a $5, what's it? Yeah, go ahead. Has it increased or decreased?
Brewster is a peak mentor home, and we have been a part of the peak program since it started, and then did the change in 2011 when it was reimbursement based. So right now, I believe it's $3 a day per Medicaid resident that you can receive if you are at the top level mentor home, and then there are other levels that are below that where you can receive. And then it's a process where you work with K-State. You can come in at the foundation level, which means you've really done, you're really starting at the foundation level, and K-State helps you work through all of those different levels up to and including the mentor home, where those are the homes that have really been doing it a long time and can teach others. So that's what the reimbursement program is for that. And then there are other reimbursed pay for performance at the federal level. There's the value-based purchasing and the quality reporting, and those have to do with rehospitalizations and things like that. And then at the state level, there is some incentives. I just looked at it the other day. I don't have it memorized, but I know turnover rate is one of them. There's some other things that the state will do pay for performance on. I'm not sure what those measures are, but if the committee would like to hear that, I'm sure we could dig into that more on the pay for performance.
Representative Concanon, I mean, Dave Halferty would be happy to come in and talk about our rate setting incentives, if you want to ask.
Great. Thank you. Thank you. Okay, back to Bill for the questions.
Thank you, Madam Chair. I don't know if it's the right place for like, a specific idea, but in reading through the complaints and hearing some of those and recognizing, there's strengths and weaknesses in every facility. And back to the paper for performance, and I was reading about, the quality of food, particularly, the time lapse for responding to call lights, those a couple of vignettes that we heard. And I don't want to make a judgment, just that call light responding is slow. But in a digital wireless age, if we had an incentive pilot or program where a facility could objectively demonstrate responding within X amount of time, that there would be a significant, and of course that's a matter of staffing, and that's expensive, and we all know how hard it is to even find folks. But assuming we can find staff, assuming there's money available, could we make a case for resident safety if we could see call light responses come down? If we have a baseline, if we have a target, we could set those call light responding times to that doesn't create a new low bar, right? So if you're already here, is there a reward for that if you're not here and you want to get? So could we somehow measure call light responding? And if a facility's didn't, and I wonder the same about the quality of food. One of the same about cleanliness. You read the story about the mice, and again, I don't want to generalize and catastrophize, but I just wondered if there are some objective measures that could be taken, and if there are modifications or the creation of some kind of pay for performance program, even on a pilot basis. And I say that in support of facilities and recognizing that most want to do a good job, but I also say that in support of resident safety, public health, and other things. So I'll just leave it at that. If it's a specific idea worth pursuing, maybe we could do that in the one of the working groups.
Okay.
Thank you.
Thank you. It's Camille I had next.
Just a quick comment on a great idea across the aisle, room over there. I will say with call lights, though, that they do have technology They do give reports. We ask for them. We also know that residents tell us is that they come in, they turn the call light off, so the report says that, but they don't go ahead and do what they needed to do. So they will say, oh, we'll be back, or, they just don't. So it's not 100%, but, you would have to maybe do some backup interview to make sure that that really is what the report, was said. But there you go. Is it okay if I ask another question? Okay, I'm going to go back to the complaints if I can. So when someone calls in and makes a complaint, they can ask for the outcome. Do you have any stats that would show how many complaints you actually go out and physically investigate physically? And then how long of time span there is between a complaint and when you're able to do that is that a question you understand what I'm asking?
And I think I understand what you're saying. I don't have that information just readily available. I can certainly look and see if there's some way that we can kind of organize and provide that information to the committee in an understandable way. Absolutely.
There does seem to be a considerable variation in what that looks like, and I'm sure there's reasons why, but even knowing those would be helpful.
Yeah. I think just off the top of my head, one of the things that changes the amount of time it takes from the time someone calls in a complaint to the time that they hear the outcome is based off of how that complaint is triaged, because then that dictates the amount of time we have before we have to investigate. And if it's triaged at a very low level, that time frame goes out quite a ways. And up until last month, we weren't even allowed to really investigate complaints that weren't triaged at those, unless they were at those very highest levels, according to CMS.
Lee, I was going to call.
Thank you, Madam Chair. If you're going to report on complaints, one thing I would like to help understand with that complaints, if you're going to provide us a report, is how many complaints come in from facilities themselves, because we call in quite a bit, and how many come from the consumers. I would like to see that, what those numbers are. So if you're coming back to report that, could you include those numbers in your report?
Yeah, I will say I will say all of this with a very preliminary caution that complaint intake information is highly guarded information. So anything that I say I can do is not saying that my legal team said that they could do it, and it's going to have to go through their hands first. So I just want to throw that out there, but I will do my best. Yes.
Haley?
Yes, thank you, Madam Chair. Just 3 quick comments. As far as the call light, it can also go the opposite way to where we have staff that go in and immediately will give care and will neglect to shut the call light off, and that does affect responsiveness. Again, opposite sides of every story. I would also say, as far as rate setting too, I'm not sure if you're aware that on the skilled nursing homes on the CMS side, when the nurses do the minimum data set assessments, that also contributes to the rate. The higher acuity, the higher needs your population is, the higher offset your Medicaid reimbursement rate is, and your Medicare reimbursement rate for that specific individual. And then finally, to Margaret's question, I believe that may not have been answered as far as when a facility does an IDR based upon their survey, the 2567 Statement of Deficiencies is still published as it was originally cited. It does not delay the publishing of that to the public, so that is still set forth. However, it is published, and then if there are amendments from the IDR or IIDR process, those are noted on there that it was originally cited at this level and was then lowered, reduced in scope and severity, or marked as past noncompliance, or, it shows that it's changed.
Lee, when you mentioned that the facilities themselves call in, are they self-reporting?
Yes, there's a CMS regulation that any suspicion of abuse, neglect, or exploitation be reported within 24 hours. And so that's a very broad, for us, for many homes, it depends on how you interpret it, but we interpret it very, very broadly. So neglect is a very large area where if a home doesn't follow a care plan and somebody needs pureed food and they were given non-pureed food and they choked and there was an outcome that was adverse, or even if there was not, that could be considered neglect. We are required to report that as potential neglect, abuse, and exploitation to the state agencies. So that happens quite frequently.
Representative Owsley.
Madam Chair, you asked the question I wanted to ask. Is that majority of them then is reporting abuse or neglect, or would there be other complaints that facilities would make?
The majority, I believe, and this is what I would probably defer to the state agency to answer that, but it is any suspicion of abuse, neglect, or exploitation. We do not call in just general concerns with our care. We handle that with our concerns process, which is looked at during the state survey. They look at our concerns grievance process and how we handle those. But we wouldn't, if it's just a general concern with care, we don't call that in. But if we suspect that there is abuse, neglect, or exploitation, we do have to turn that in to the state agency within 2 or 24 hours, depending on what it is.
The only thing I would add to that, I think outside of the required reporting elements that we see, probably second most common, and the required reporting elements are far above and beyond what we see coming from facilities on the complaint hotline, but they also sometimes give us a heads up, and the complaint hotline is one of the easiest ways to give us a heads up about I had to let a staff member go and they're really, really mad. They're probably going to be calling you about every piece of dust in my facility, just so you know. But those types of things are also very useful for us, because then as we do get in maybe a complaint from an alleged someone else, it helps us to be able to know the whole story and be able to triage those better. But then the other thing is when we do those facility reported incidents, or FRIs, we then take into account what the facility has already done when we're doing our triage process. So just because there was maybe a really adverse outcome, that doesn't necessarily mean that we would triage it as IJ, because maybe the facility was also able to provide us all the information to show us that they responded appropriately and have already completed their own investigation showing any of the negative outcomes and or interventions they've put in place due to that incident.
Good. I've got a question online from Linda Mowbray.
Thank you, Madam Chair. Linda Mowbray, Kansas Healthcare Association. I tried to put this in the chat and it's not going to be available to everyone, so I'll simply say that the rate setting methodology is available in the Kansas Register. The current rate methodology for fiscal year 22 can be found in volume 40, number 22, dated June 3rd, 2021. And that goes over the peak incentives that we were speaking of, outlining what Lee Chaffee had mentioned, the 50 cents to get started, the $3 a day once you've reached a certain level. It also shows the case mix adjustments for staffing and your retention, and just a whole host of information of what goes into that nursing home rate setting. I will say that we actually are beginning some preliminary discussions with KDADs, and we thank them for these beginning preliminary discussions about rate setting formulas going forward in the future. This is probably way too in the weeds for this committee, but Haley spoke of the MDS and the case mix. That method is changing on a federal level, has changed. So there'll be a different scale, if you will, that will help us with that rate setting and determining what the acuity level of an individual is. So this truly is an opportune time to gather ideas and data and look at how do we rebuild the rate setting for going forward. Thank you.
Next up, I have Camille.
This is Camille Russell. I have three things. I'm sorry. So I want to go back to the IIDR, the dispute resolution, and that there was a comment about the statement of deficiencies, or the 2567 is the forms number that's often gets referred to. And that the original one does get published, as well as and is open to the public, as well as the final one. I have a question that I have to ask you. I sort of know the answer of, because we have a hard time getting those, unless you were on site at a facility, which they're required to post them, about KDAD's posting those in a timely manner. Is there any, sometimes it's months, and you can look on the KDAD site now for the public to view the 2567s. Is there any plans to be able to improve that? Probably technology, or maybe it's staffing, I'm not sure which, but to be able to get that 2567, that statement of deficiency, available to the public quickly.
Any 2567 is available to the public upon request after 14 days from issuing to the facility, according to the federal requirement. As far as how they get posted onto our public site, it is a bit of a technological thing. We use I believe it was kind of a self-built program called CODA. And what happens is when a facility is issued a statement of deficiencies, a nursing facility in particular, they're required to then provide us a plan of correction for any deficient practice cited. And the way and avenue in which they do that is by going into their portion of CODA and entering a plan of correction. But then the way the CODA system works is that none of that information is published, our side of it or the facility side of it, until those citations have been found to be back in substantial compliance. And achieving and maintaining substantial compliance takes a little bit longer for some facilities than it does others. But until the investigation in its entirety is closed out, our system doesn't really have a workaround to get it published out on the public side of our database before having completed all of those tasks.
So you sort of answered the second question I was going to ask of you about the plans of correction, because again, be able to see those. And so what you're saying is that same technology issue may also be impacting being able to get the plans of correction. Okay. And then the third was about the self-reporting and the address by facility. And I guess I have a comment of observation from ombudsman being in buildings and that situation and the investigations in that regard. Some facilities are really great about self-reporting. They also are really great about wanting to do a good job and improvement, and that's really what that's about, is being able to improve. And so with those facilities, it's really probably very easy for you to accept what they've done, look at it, and probably have that line up with what a resident then would say happened. What we find a lot of times, though, is, or too often, let me say too often, we find too often, is that there is an acceptance of what the facility said happened as being somehow a higher level than what the alleged victim or the resident says happened. And there are places that, honestly, we're on site and sometimes see things, and so we know that if we've had 4 residents tell us that same thing, and we saw some of the similar things happen, that sometimes the review, the surveyors, what they're looking at and hearing are records that say something different, and people that are saying something different, and residents tell us they have not even been interviewed sometimes. So I just want you to keep in mind that you have, again, different levels of operation out there in buildings, and that probably those cross-checks are important to make sure that, unfortunately, I've been doing this now 6 years. It's a different world now than it was even 6 years ago in the level of what is put in documentation versus what we physically even saw. So, and that's just with some facilities, but the problem is it exists. So whatever cross-checks you can do to make sure that what the documentation said, why is that not lining up with what the residents said happened? That happens over and over. There's probably more questions to ask. Thank you.
Bill has a question.
Madam Chair, thank you. Bill Persinger, Topeka, Vallejo Behavioral Health Care. Just got one general comment as we come up with recommendations, ideas, or various kinds of suggestions. I don't think I spoke on this, but if we would consider keeping in mind a principle of scalability. When I started my career in mental health, right after Abe Lincoln got elected, I worked, it was pretty much my duty to go to nursing facilities for mental health out in western Kansas, Ashland and Coldwater and Kinsley and Haviland and other places. And, some of those are small facilities, and what works in one area, probably ought to work in another area. And then there are large facilities here in the more urban areas. So if we could keep in mind scalability, because if I'm a nursing home administrator in Coldwater and I want to do this thing, is it only something that a facility with 400 or 500 residents or 200 could do? So if we could keep in mind scalability. And then within nursing facilities or long-term care facilities, are there anything like a quick response team? In mental health, we have crisis teams that can respond pretty quickly. Are there any, that could, it's probably just I don't know, just an idea. It may not even be doable, but somebody that could respond. And I understand that, responding as quick as it can be with staffing levels and, multiple duties and things like that, and training. I heard needs for training. Would there ever be a need for a facility that could be properly funded to maybe have some kind of pilot, a quick response team? And I don't know even what that would look like. I'm just asking, trying to generalize from one field to another. So thank you, Chairman.
Yeah, thank you. That's part of the reasons why we have representatives from different walks of this senior lives. And so thanks for thinking out loud. Some of these discussions will be probably recommended to the working groups for discussion. Let's see, I have Deborah Zier online.
So Linda opened up, and there was previous conversation about how nursing homes are reimbursed, which has a direct correlation to what they can do for care and services. And in that reimbursement methodology that Linda Mowbray referenced is also how the structure for paying for direct care and indirect care staff. And if you decide to dive into that extremely dense document, you will see that there are caps put on the amount that can be paid. And those have maybe become problematic during particularly the second half of this year, when staffing agency and wage wars and so forth have become so rampant that the reimbursement is not keeping up. It cannot keep up because there's a lag in when rates are set and what's been happening. So I just want to bring that to your attention, that reimbursement is not in any way, shape, or form now keeping up with how much staff are having to be paid. Thank you.
Thank you for that. Do we have other questions? Comments? Thank you, Lacey. I know we got into some other topics besides yours in our discussion and kept you standing there, but I appreciate you being here and your presentation. Excuse me, that concludes our morning agenda. So done early again. Let's see. Hang on just a sec. Okay, we'll recess for lunch until 12:45. House time.
Cisco WebEx meetings.
Hi, Charlotte.
Okay, welcome back, everybody, from lunch. We'll jump back in here a little bit early and maybe be done early. That would be nice. So we'll start out the afternoon with a presentation on the survey process from a provider perspective. And first up, we have Charlotte Rathke, administrator from Locust Grove Village in La Crosse. Charlotte's on WebEx.
Hello, this is Charlotte. Are you hearing me okay?
Yes, we can hear you. Welcome.
Okay, thank you. Good afternoon, Chairwoman Concanon and members of the Kansas Senior Care Task Force. Thank you for the opportunity to speak and share my story this afternoon as a small, standalone, rural Kansas provider. I am Charlotte Rathke. I'm the administrator here at Locust Grove Village. We're a not-for-profit organization in La Crosse, Kansas, and been in service here, started by our community with a need for elder services back in 1978, so over 43 years. A full continuum of care retirement center, multi-county region, providing 38 skilled beds, 14 units of assisted living, and 16 independent. We are a 4-star provider within the CMS rating structure, hopefully soon to be 5-star, as our zero deficiency annual survey review was recently completed, and we're quite proud of our success here in this community. I've been the administrator here for over nearly 18 years, but my entire 37-year career has been committed to caring for elders of Kansas in nursing homes. I define my success by resident and family satisfaction, operational stability, and survey and regulatory compliance that I have been successful in as leading few organizations under my administration. It is a challenging and an often daunting task to operate a retirement community, and that's what I hope to just give you a sense of this afternoon as we talk and share. As a skilled nursing facility, CMS, or the Centers for Medicaid and Medicare Services, guide our operation with many regulations. In 2017, over 696 pages of regulations were revised. The requirements of participation for us to implement. And those regulations are not just a single page per regulatory issue, but rather, multiple pages. And for example, I share here about the pressure ulcer section, almost 17 pages worth of guidance and expectations for us to consider: prevention, assessment, risk, skin condition, repositioning, what kinds of surfaces, monitoring and treatment, pain and dressings. All of those areas provide opportunity for, regulatory compliance or non-compliance. Those requirements include other very comprehensive program expectations for us, like emergency preparedness and response, quality assurance and performance improvement, trauma-informed care, mental health of elders. All of these, including a facility assessment that outlines everything about your organization, down to whether we have soap in the dispensers available. It's comprehensive. It includes, policy, process, procedures, education, training, all of these things for implementation and review, which then takes place in that survey process. Over 40 long-term care pathways that are reviewed by the state agency under contract with CMS. Focus off-site as well as on-site before they come on into your buildings unannounced any time of day or night. But those agencies are just a few of what we deal with. We also deal with the Department on Aging, OSHA, the Kansas Fire Marshals, the Kansas Department of Labor, the Kansas Department of Transportation, state agencies. If you're in assisted living services, the state guidance, you have home and community-based services, home health. All of these come with their own rules, their own regulations, their own expectations of processes, rules, survey, education, and training. It doesn't end, and it's overwhelming as a provider. Medicaid, Medicare, how to help your facility and your residents be sure to get their payments, Social Security, insurance providers, the MCOs, our managed care organizations that we deal with. It's exhausting. As a small provider, there are no layers of administration to help me. There's no one for me to pass that on to. I am involved in every phase of the organization besides compliance, hiring, marketing, payroll, billing, fundraising, building and remodeling, strategic planning, budgeting, all, board work, in addition to all these compliance areas that are already mentioned. 24/7, 365 for the last 26 years as administration in the state of Kansas. Is it operating properly? 365 days a year, can't shut the building down, can't say, hey, we don't have enough staff to serve your dinner tonight. I literally live and breathe my work, and it is exhausting. It's not just me, though. It's not just my position. Our director of nursing also serves as a charge nurse, 12 to sometimes 30, 40 hours a week, depending on the staffing needs, whatever shift. And this person happens to drive nearly an hour and a half to come to work at Locust Grove. Our social workers, also our beautician, the activity director is also driving the bus and assists as a medication aid. Employees can't keep up. Employees are weary. They break, they're beat down. They feel like they don't do anything correct. And honestly, all we really want to do is just care for our elders. Give us the time to do that, to spend the time to provide the person-centered models of care that we believe in and that we support. But with all of this overload, how do you have time to do that? We're overloaded with all of these expectations, and I haven't even begun to think or mention the last 21 months of COVID-19, shutdowns, testing, vaccinations, boosters. You go on, NHSN reporting. How can we stay in compliance? How do you keep up with that? Compliance relies solely on staff. Doesn't matter how fancy a procedure and what kind of policy I write, it requires and relies on competent, dependable, dedicated staff. And our workforce is a disaster. It is extremely difficult to employ persons who want to work in this punitive, regulated building and organization. We are using agency personnel, and you have that same responsibility and expectation of making sure that they are meeting the compliance expectations of your organization. But this constant punitive nature of the regulatory approach just doesn't work. Over and over, we're faced in every single instance from these agencies with deficiencies, with fines, with plans of corrections, with compliance expectations. Again, taking time away from and resources away from the care of the residents. This punitive system doesn't work. If it works, we wouldn't continue to have poor performing facilities in the state of Kansas. I would not hear family members walk into my building and praise me for the smell or lack thereof in our nursing home. It infuriates me as a provider that we still have organizations in our Kansas delegation that provide that kind of care. It doesn't belong. So if it worked, why are they still in business? And it's also frustrating for those of us who do try to operate a good facility, meeting compliance the best we can. There wouldn't be poor performing facilities if we indeed held up to this regulatory expectation. Elders, they wouldn't fear moving into our facilities. They wouldn't fear what they have to give up to come in or what kinds of oversight's going to be on their lives day in and day out. Even though we know they need care and their family family members are exhausted with the care needs that they have. The public, well, maybe they wouldn't despise nursing homes as a part of the healthcare continuum, and you wouldn't hear things like, I'll do anything to keep my mother out of one of those places. People don't want to come work here. It doesn't help us that the kind of work that we do is constantly beating us up. OBRA 88 outlined our current survey and enforcement process. And our leading age national association has called for the National Institute of Medicine to revisit this program. Is it effective? Is it efficient? Where is it failing? Since 1988, I certainly believe that our expectations and our processes should change after 33 years. We should be able to work together. We should have a collaborative approach. We should be seen as partners in care with these agencies and this process. We need quality improvement methodology, maybe an accreditation system like hospital providers and almost every other healthcare provider in our American healthcare system. Providers are working tirelessly and they need support. But foremost, the elders who we serve across this great state and across our nation deserve this effort, and it's time. Thank you for your listening and allowing me to share my experiences as an administrator in a long-term care single provider in the state of Kansas.
Thank you, Charlotte, and thanks for what you do for the seniors in your community. I can tell that you're very passionate about it. And we have one more conferee in this section. I think we'll go ahead and hear from him before we take questions. So next up, we have Willie Novotny, the president of, how do you say it, Advena Living.
Correct, Advena. Can you all hear me okay?
Yes, we can hear you just fine.
Okay. First of all, I would like to apologize for my apparent lack of professionalism. I'm actually in the back seat of my pickup truck in delivering my testimony. The place where I was going to be at today didn't have adequate wireless service, so thank you for your understanding.
Laughing because we've had big discussion today about broadband. So.
It's great.
Okay.
So my name is Willie Novotny. I started my career in 1995 working as a nurse's aide, and I've been a licensed administrator since 2003. I've had the unique opportunity to operate at least one facility in each of the Kansas survey regions. I'm currently the president and CEO of Advena Living. We're based out of Manhattan, Kansas. We own and operate 7 small to mid-sized senior communities in the eastern half of the state of Kansas. And all of our homes are located in either very rural areas or underserved areas of larger communities. And in most cases, we are the only local option. And so it's incredibly important for us to stay available so that people don't have to move in order to get services. Before I deliver my testimony, I want to establish that that our standards as an organization are incredibly high. We don't accept mediocrity in any way. However, we're in a very human business, and there are many opportunities with all of the various people that are involved in care delivery throughout the day that mistakes and oversights can occur, and we correct those to the best of our ability. I think that can be said about most every caregiver and provider in the industry, and just trust that none of my comments with mistakes or corrections are misconstrued as acceptance of those, and that we continue to do the best that we can. Also, to summarize or to capstone my testimony, I think the most important thing to understand about my comments or anyone's comments with the survey system is that it's the system that's the problem, and not necessarily the individuals any more than that could be said with caregivers in the industry, that we're in a really bad system. The punitive nature, as Charlotte was referring to, it puts everyone in a very fearful position, and that includes surveyors. It's not easy to be in a position where you're the perceived bad guy, and it's not easy to be in a position as a provider or a caregiver where you are potentially in the position of being the accused, and so that creates a very natural defensiveness on all parts that if we don't guard against it, it can lead to misunderstandings and personalization and contentiousness. And so I hope that I'm going to be pretty specific with some comments about my thoughts and experience about the survey system. And I hope that everyone understands that I have and our organization has an excellent relationship with the survey agency, with the surveyors, past and present. Most of my comments, just due to turnover in the survey agency that has occurred over the last few years, most of my comments aren't even going to refer to people who may still be within the agency. And the reason that I bring any of these things out is in the hope that I see some signs for the future that things may be progressively able to be getting better and more constructive in providing better resident care, which is the goal that we all have. So to go back to the beginning of my written testimony, I've been in the business for a long time, 20 years as an administrator, and when early on in my career, the nature of the survey environment allowed for a lot more interaction and room for conversations and explanations, subjective determinations in what things constituted the citation of a deficiency and what things were merely communicated as a concern of something that a provider needed to work on. And most of the negative changes that I've seen throughout my career began in, I believe, about 2008 when the federal government instituted the QIS survey process, which was meant to make things, I believe, more objective. And I think that therein lies the major problem, is that the regulations are not objective. The regulations do not specify, other than in certain environmental conditions, that they don't say that you need to explicitly do this, and do that. The regulations simply state that we must have a system for assessing any areas of the building that a resident may get into trouble, and we must have a system that prevents them from doing so. That's the regulation. And there's nothing objective about that. Determining whether or not your facility policies and procedures meet that standard, that's a subjective process. And determining whether or not your actions and your behavior lined up in accordance with what you said your process is going to be, that's also a subjective process. So I think the QIS survey that I hope I have the year correct. Someone will correct me, I'm sure, that about 2008, that was when things kind of started to go downhill, in my opinion. And I say that because I think that that makes it an extra. There needs to be an extra emphasis on everyone's part, survey agencies, both CMS and KDADS, and providers' part in making sure that we're maintaining the most positive and supportive relationships with each other as we can, and understand that even though the system is what it is, I see changes every time there's a new head of CMS. I see changes every time there's a commissioner or secretary with KDADS. And so that tells me that even though we might all think that the system is what it is, there's room in there one way or another, whether it's for the better or worse, depending on what your opinion or evaluation is of that. There's room in there for people's opinions. So back to the nature of the regulations themselves, the the primary issue that I've seen that I think has really negatively impacted most providers over the last recent years is that in previous years we were required to have a system for meeting the regulation, and then once we have a system for meeting the regulation, whatever that is, the CMS and KDADs, they don't have a role in really telling us what system it should be, just saying that we should have one and it should meet the intent of the regulation. And then secondarily, we need to make sure that our employee behavior, including ourselves, matches up with whatever that system was that we decided we need to have. And early in my career, the evaluation about what constituted a cited deficiency was, number one, did you fail to have a system? And if you failed to have a system, that was usually a pretty big deficiency. And then number two, if you did have a system, did you follow it? And if you did have a system but didn't follow it, that was a deficiency, but it was a lesser deficiency. But nonetheless, the keys to not having a deficient practice were, number one, making sure that you have a system, and number two, following it. What I believe has changed over the last several years, but more intensively the last few years, is that our surveyors are no longer just evaluating whether or not we have a system, but rather evaluating their opinion of the adequacy of that system. And secondarily, and most of most concern, is that once we have the system, instead of just assessing that we followed our system, irrespective of the outcome, that we're being surveyed on whether or not the opinion of the survey team agrees with the decision that we made at the time. So what we're experiencing is in our annual surveys, we of course there's a lot of analysis on charting and looking at different metrics and interviewing and all of those things. And what we're finding are that a lot of our deficiencies are amounting to something that happened anytime from 2 months ago to most recently, because of the gap in the survey window, up to 18 months ago, that we missed a thing that, even though we put an intervention in place, because the survey team didn't agree with that intervention, then we receive a deficiency. And that one thing there, as far as the second guessing of the decisions that were made, that's a new thing for me. I've been very experienced in and have received deficiencies deservedly in any of the communities that I've led. I've received deficiencies for missing the regulation by not having a system. I've received deficiencies in my communities for, even though we have a system, we failed to follow our procedure, and so we were deficient in a practice. I've received deficiencies for those two things, and I agree with them. That's how it should be. What's new for me is having a system that meets the regulation, following my policies and procedures in that system, yet having a deficiency cited because the survey team disagreed with the decision or the intervention that I put in place at that time. And that's the primary point that I would like to deliver, because unless I've missed something, I'm not sure that is a requirement. I believe that whether it's somewhere from Washington, D.C., or in translation through the regions or to Kansas, I believe that is someone's interpretation. And I believe that is something that we should look at in making some changes on. And I would love to be a part of that. As I stated in my written testimony, I'm very hopeful about the future of being able to return to some of the good, open, transparent dialogue that we had before. I think that that since Deputy Secretary Scott Bruner came along, that there have been some very positive changes in moving that direction. Tomorrow, I am participating in a open dialogue session and hope to be able to positively contribute in that. And so I think that there are some good things moving in the area of becoming more collaborative with each other, and I just hope that those continue. This concludes my testimony.
All right, thank you, Willie. So now we'll take questions for either Charlotte Rathke or Willie Novotny. Is everybody going to be quiet after lunch? It looks like we have a question on WebEx from Rachel Perner.
Thank you, Madam Chairman. I'm curious. I'm an attorney in private practice and served some time on a CCRC nonprofit board here in the Wichita area, which is a very large board. And a part of our preparation year-round for these studies, these audits to come in, involve the retention of various consultants and experts who would come in and review protocols, systems, procedures, etc. And I've always been curious about how that works for smaller facilities, such as the one in La Crosse or the various small communities that were being testified to. Thank you.
Was it for either Charlotte or Willie, your question?
Yes, madam.
Charlotte, would you like to respond?
Yeah, if I'm understanding exactly your question, what I'm going to talk about is what we would call a mock survey. Is that what you would mean? Like an expert outside coming in and kind of reviewing us?
Yes, that would be a part of it. But even beyond that, kind of a more in-depth study into the systems and the compliance leading up to those mock surveys.
I would say for myself, I rely heavily on my membership in an association like Leading Age Kansas, Leading Age National to help provide insight to that. For instance, through COVID, there have been, at the beginning, daily calls from our national offices, weekly calls with our state where, they're providing help to you as a local, as the local provider, guidance, interpretation, because there's just no way that I can hear all of it, listen to all of it. As far as outside resources coming in, the most example of that we have used, we've done that, for instance, with like financial or operational oversight, brought in like an accounting group or an expertise person that does that kind of, review of our, our overall systems related to finance or employee benefits. But otherwise, we've hired, like I mentioned, nurse consultants, people who do that privately to come in and look at our, help us review our systems of compliance and service to our residents, much like a team would do. So that would be my examples of how I utilize those things.
Willie, do you want to respond as well?
Yes, thank you. So we, as a what I would call a small regional provider, we are able to afford having a regional team of a handful of very experienced people, either former facility administrators or former facility directors of nursing, one of whom is my wife. And it's a full-time job. I'm very familiar with what was being referred to previously as the annual mock survey. We always did those, and that usually helped you identify anything that you needed to work on, um, that that you needed to get ready for the examination and in time to fix it so that you were ready. With the change that I was referring to in my testimony, that there's no longer a window where a mock survey really does a whole lot of good, in my opinion. You need to do a mock survey about every month in order to be ready, because you have to take care of everything that happened every month in order to survive the current environment and the system and the way that it's put together. So this includes myself as the CEO. Even though I'm not a clinician, I spend a great deal of my time looking at different outcomes and charting methods and systems and policies and procedures in trying to stay on top of things. And between staffing and compliance activities, that's about all that we do when we're not working in a facility ourselves.
Okay, Rachel, let's see. Yeah, that was Rachel that originally asked the question. Are you comfortable with your responses, or did you have anything further?
I guess my follow-up would be, do you see a role to play from the regulators in that educational piece leading up to the surveys?
Willie, do you want to respond to that?
I couldn't quite hear the question. I think it was asking if we see a role played in education by the surveyors. Is that correct?
Yes, if
Yeah,
that would be something helpful.
it would be incredibly helpful. It would be incredibly welcome. That is how things used to be somewhat, that the surveyors came in and they did their job, but there was also a lot of education that was provided at the same time about things that they saw that we needed to be working on. And I would love to see us return back to go in that direction.
Charlotte, do you have anything to add to that?
Not really. I do think that it only makes sense in my mind that they could be that kind of resource, because they're in multiple places. I mean, that's what they do all day. They're in and out of different facilities. So they would, the surveyors would experience, observe good things and how to share that. To me, that's, what collaboration is. But I do think there are times that, they're observing something in the survey process where they will, offer hey, don't forget that, or you might notice this. And again, it depends on the person, certainly, and kind of what the context is. But I do think we used to, I agree with Willie, hear that more. And then we've been through a phase, I guess, where it's like, oh, we can't tell you, because then if you do that, you'll come back on the state agency and say, but your surveyor told us it was okay to do it this way. And now, so I think there's a concern of that they're not willing to share sometimes because of that as well.
Okay, thank you. We'll move to the next question from Linda Mowbray.
Thank you, Madam Chair. Linda Mowbray, Kansas Healthcare Association. I wondered if the conferees could speak to the role of the QIO in Kansas. The contract has been subcontracted to Kansas Foundation for Medical Care, KFMC. And I wondered if they could speak to the role they play in quality improvement, and whether you see their role as helpful or whether it could be expanded. Thank you.
Charlotte, you want to go first?
We have done a few years ago, we did some work with KFMC on some targeted areas of concern. But I'll be honest to say that, you know, they are a resource available. I see like their education opportunities, or they will present, um, um, you know, information so that it gets passed along to us. But I honestly do not use their services much at all.
Willie, do you have anything to add?
Yes, we love KFMC. We greatly enjoy working with the QIO. We use the QIO composite reports every month in managing our own compliance activities. I don't think their budget is big enough. I don't think that they have enough. I don't think that they get funded enough to do the outreach and the education that they need to be doing. I think that they're great in tracking activities and in providing a framework that may be able to be implemented by an organization that has the resources to do it. But if you don't have that infrastructure to be able to implement ideas or processes that may come from KFMC, it's hard to do it. And so either KFMC needs the resources to be able to help implement the processes and ideas that they have to recommend, or it needs to come through funding to the providers themselves. Either way, the implementation of quality management is vastly unfunded and unattended to in long-term care, in my opinion.
Okay, thank you. Any other questions? Charlotte, just out of curiosity, are you in La Crosse currently?
Yes.
Okay, just those of us who are on WebEx can see that there's not enough bandwidth for your picture to show up on our screen. So we've been having a discussion about broadband today.
Okay. Yes, I'm in La Crosse.
Okay. All right. Well, thank you. Thank you both for your testimony. And we'll move on in our agenda to a presentation on Kansas Guardianship Program. Excuse me. Jean Crane, how do you say it? Executive Director, Kansas Guardianship Program. I apologize. Welcome to the committee.
Thank you very much. I see some longtime professional friends and colleagues sitting around the table, and a few that I saw who were on the video. It's a pleasure to be here, Madam Chair, members of the committee, and the person that I've been communicating with to get this set up. And now you just gave me pause because enter would be magic. So thank you for this opportunity to talk about the work that we do. And want to start with that our agency, our program works with a sliver or one piece of guardianship in Kansas. And so basically that would be those individuals where they do not have family members willing, able, or appropriate to serve in that capacity, and that our model then is to recruit and train volunteers to serve in that capacity. And there's a collaborative model structure that I'm going to be talking about. This is a collaboration that has been going on for more than, if I tell you the dates, it's going to date me, but for many, many years, where we've worked collaboratively with Adult Protective Services, and that is the entity that can make referrals to us, as well as the state hospitals who are under KDADS. And that came about, obviously, because of the changes in the state agencies roughly 10 years ago. And we do receive funds through the state of Kansas. So there's the model and what it looks like. Eligibility criteria for a potential person who may need guardianship, an adult. There are Medicaid recipients, no family, and an open DCF case for abuse, neglect, or exploitation, or even self-neglect. And then the third part of the process is the legal component, which means you need to petition the court. So there's a lot of moving parts to guardianship, and I'll address some of those as we move through as it relates to the work that we do. In our screening process, and this information is also available on our website. We are thrilled with having been able to upgrade that, update it with a lot of good information, not only related to our program, but also related to guardianship in general, that if you want to do a search and you want to learn a little bit more, we have that information. So for those volunteers that we work with, there's an application process. And in that, we ask for references. We also require that we do criminal background checks, as well as we check the Department for Children and Families Adult Abuse Registry, as well as the Child Registry. We have references that we follow up. There's an interview, and basically it's a process of learning to know the person. What do they bring to the table? What will we want to look at with them as it relates to a potential case or situation they might want to be involved in? One of the things that's important for us is looking at the potential for conflict of interest. That is in the statute. It was added in 2009. And it's important to look at it to know whether there's something that has the potential to be problematic for the individual for whom we're trying to advocate. We have a matching and a nomination process. So we don't simply go and say, hey, Annette, I think I have a case and I want you to take this on. For us, it's more about how do we look at the person for whom we are being considered a guardianship, and also the person who may be the advocate, we're asking to be that person's champion. And so it really becomes a matter of a conversation. For the most part, we try to facilitate a meet and greet to see if there's any obvious immediate barriers, and then to, once that happening has occurred, then to have that becomes the nominee, of which we return that information to the referring body. Part of our training, I think, is important to know. These are the kinds of things that we look at. We talk about advocacy. We talk about the role of a guardian in that position of being an advocate. We talk about the legal duties and responsibilities, things you can do, things you cannot do. It's a matter of trying to educate people about all the way around so that they can take to the table saying, this is not something that comes under the purview of guardianship or conservatorship. We talk about what are the payment sources. I'm sure your committee has talked about the Frail Elderly Waiver. You've talked about the PACE program. You've talked about the IDD waiver, a number of other ways that we provide funding for vulnerable folks when their own resources are not adequate to take care of those. We talk about the state agencies that a guardian conservator would need to potentially interface with, and what are their respective roles and responsibilities. We talk about the importance of monitoring, monitoring those supports and services that are being provided, whether that be in long-term care, whether that be in the community, or whatever residential situation the person is in. We talk about abuse, neglect, and exploitation. A guardian is one of the mandated reporters amongst a very, very long list. of Kansans who are required to make reports. And we talk about the importance of planning, moving through the funeral burial planning process, which we could probably do a whole session on that one alone. And then, of course, there's how does our agency and how does our program work. One of the things that once a person goes through the nomination and is appointed, that we bring that person on board, we have a contract or a memo of understanding, which is essentially what they say to the court that they will do, and it allows us then to provide and offer a small stipend to offset out-of-pocket expenses. In fiscal year 2021, we served 1,394 different individuals, and that was through a volunteer corps of just under 775 people. And the individuals that we serve are persons who have intellectual developmental disabilities, mental health, behavioral health issues, and aging relating, and many, many other types of combinations where a person may have been determined by the court to need additional assistance. Just for those people who like stats, I didn't put them on here, but I do have them verbally, that 57% of the people we serve are 60 and under. This 55-year being an aging person, I think needs to be revamped, and it should be closer to 70, but they don't consult me when they do that, but nonetheless. And the other part is that we serve a significant number of individuals with developmental disabilities. Many of those have been in the system for a long time. One of the things that I think is important to know is about 71% of the people we serve live in the community or in community residential programs. I differentiate those from long-term care, assisted living, state hospitals, and nursing facilities for mental health. And that has been a marked shift for us over the years as we've seen many more supports and services being provided and more people who are eligible for those supports and services, and knowing that those lists still continue to be long. We have about 73% of our cases are guardian only, and roughly 25% that includes guardianship and conservatorship. And that was one of the questions I was asked to make reference to. And just for your reference, this is our map, our regions, none of which overlap with anybody else's. We want to be unique in that. And you can see that the regions get larger as we get into western Kansas, where resources are more spread out. We have 7 field staff who do the recruiting, the training, and then the ongoing support for those volunteers. We have offices Manhattan, Kansas City, and Wichita. I want to just do a slight pivot here because I can't stop myself from doing a mini guardianship overview, because I think that there is a tremendous amount of mythology out there, misinformation. And so I want you to be aware of those things that I think, through my years of experience, are important to be aware of as you are navigating, as you are listening, as you are clarifying, and so that you have a better understanding that what guardianship and or conservatorship is about. So one of the first things that we look at, and I will stay within my half hour, I hope, is to look at sort of what does the continuum look like before we consider guardianship. And that is something that is continuing to evolve and morph, not just in our state, but also nationally. For those of you who have had opportunity to learn about the National Guardianship Network and their 4th summit and the things that they were working on to say, here in the next 10 years are the things that we really need to wrestle with in a different way as it relates to guardianship. So when we look at alternatives and we talk about the term of least or less restrictive, then we sort of start out with where each of us is in the community. What kind of support network do we have? Very, very few of us function in isolation, where we don't have people around us with whom we confer, we have conversations with. We've been to the doctor We've heard this particular kind of medical news, and our hearts are pounding because we need to be able to talk about it. We need to sort out. And so many of us have that informal network of people. And sometimes that can go into the financial piece, which relates to bill payment. Maybe we're struggling with that. Are there ways that, are there entities out there, are there organizations that can help me with that? Just because life is kind of overwhelming, whether it's those of us who are in this room or those people who have other kinds of medical, physical, or emotional challenges that make it very difficult for them in their day-to-day. We can take that sort of to the next level, and we talk about social services involvements. You've heard about what the Department for Children and Families can do to assist people. Kansas Department of Aging and Disability Services. Within those local people, the old-timey area agencies on, I can't even say it, sorry, Annette, that have the ADRCs within their entity to be the resource, to help guide people toward resources, a huge, valuable part of our system. And there's still, I know you're surprised, there's still a lot of people who've not heard about it. We've talked about, and I'm sure you've heard about the community developmental disability organizations on the IDD side, and there are other types of entities out there. Know that my experience is 99% when we don't have funds. So that's usually where my presentations kind of lean. But of course, there are many people where guardianship or conservatorship is considered, where they have resources, they have insurance, they have an ability to pay for supports and services. As we move through the alternatives, we talk about Social Security, Veterans Administration. Those are both federal entities that can name someone to handle another person's funds. It's a federal designation, and sometimes they don't have a strong sense that Kansas law might have some other things to take into consideration, just saying. But that is a way to have a payee who can be named, whether that's an individual or whether that is an organizational payee. We go down the road to durable powers of attorney for finance and healthcare. You've probably heard the supported decision-making legislation that's been introduced. Kansas statute has an option for voluntary conservatorship, which means I can ask Margaret if she would help me with my finances. It's a court appointment, but we don't have to have a determination that I lack capacity. And then we move into guardianship and conservatorship and full guardianships. Definitions, and I always wrestle with the chicken and egg. Do I tell you about the definitions first before I talk about the least restrictive? But in this case, I chose the least restrictive conversation. So statutory language is a ward is a person who's been determined by the court to need someone to assist them in decision making, and the statutory language of who that is or what that role is guardianship. Conservatorship is anything that constitutes the person's estate or finances, and then the person is referred to as a conservatee. And so I also talk about the representative payee because it is something that is significantly misunderstood. You can be the conservator for someone, but you still have to make application through the Social Security Administration or for VA to be able to access those funds and provide a report about those. Types of guardianship, this was one of the questions that was, so we have guardianship of the person, conservator as it relates to financial matters. This voluntary conservatorship option is currently in statute, which means we can ask for assistance, have court overview, have reporting, but not a determination on disability. This statute covers minors all the way through the aging continuum. We have an option for a temporary guardian conservator, which means if there's something imminent, meets the statutory definition of imminent danger, that's something that could be posed to the court to name someone to deal with that very immediacy. Successors is if you have a guardianship established and you want to make changes. You can do that. It usually does not require re-adjudicating or redetermining that the person needs that, although that's considered in many situations. Statutory is a standby, and then there's options for co, and that gets into the weeds a little bit, but if you want to know more about weeds, come and see me. Guardianship in Kansas is handled, we are one piece of the puzzle. They believe that the vast majority of guardianships are immediate or extended family members, although I don't believe there's a statistical verification of that, but that's generally what's considered nationally. Other people who serve in that capacity may be attorneys. Banks sometimes serve as trustees. There's a corporate guardianship program in Johnson County called R-Care, and there are individuals who do private guardianships for a fee for service. In your packets, obviously you can't read this, but in your packets, I'm hoping it's of the size that you can. I just laid out sort of what the process looks like when we get a referral, what we do during that time period, what does APS do during that time period, and then what happens when it goes to legal. Each one of these pieces takes time and takes due diligence, because what we're looking at is something that is rather significant. It is significant from many, many perspectives, one of them being is that you will have somebody, if you are adjudicated, to make some of your decisions, maybe not categorically all of them. The other part to that is that we want to do our due diligence. We want to ensure that that evaluative piece has been done, and that the person's due process rights are honored within the court system. As I mentioned, each one of the procedural pieces to this takes some time. Some of these things are spelled out statutorily. If you want to know, probably the shortest time on a temp might be on an ex parte order that gets in front of the judge and the judge says, we'll do this now. Or it may take the due process time period to put those in place. So in your packets, I also included a more detailed what is involved from the time you petition to mandatory orders, notices, and then taking you all the way through that legal process. Which takes us to the other part of what we do ongoingly is to recruit people. We have people who are joining us. We have people who are retiring. One of the things that I want to call attention to is the fact that while we can't do everything, we can do some things. And that process of putting together the right guardian and with the individual and what does that person need becomes a really significant process. And if we are good at it and we put the right people together, those can be relatively long-term guardianships and conservatorships. And in that, what I can share with you is that about 45 to 47% of our volunteers have done this for 10 or more years. So if you do the other side of that, you have some that are less, but a significant commitment on the part of people. Why is that important? It's important because there's continuity. It's important because our trust relationships develop over time, and particularly because some of these individuals may not know each other. Although some of our recruiting strategy is to try to find someone who's already in that person's sphere who might know the person. Maybe they hadn't thought of this, but it's something that we can provide information and opportunity for. I think that takes me through the overview that I wanted to provide for you all. And hope that along the way I answered some questions. This is not a black and white issue in the sense of, or it's not an either or. And there are many, many moving parts to it. And things that are important for me are terminology. I may get a call from somebody that says, well, I'm the guardian for my adult child, and I'll ask them, did you ever go to court? Well, not that I remember. Well, then maybe you're not. Well, I'm the mom, or I'm the dad. So a part of what we also do as part of our equivalency to community service is provide information when those kinds of calls come in. My parent is ill, they just had a stroke, they're not making decisions. What do we do? How might that look? Where do we go? So that is a part of what we are able to do, which I'm grateful for. And those often are long and emotional calls. Because by the time they get to us, and I'm not doing any bragging rights on this, I'm just saying, by the time people get a call where somebody maybe has a little bit of knowledge base, the desire, the need to be able to share beyond the level of frustration that they have is significant. And so, if you like, that's your Kansas dollars at work. Okay, questions?
Well, thank you for being here, and thank you for your presentations. I know you answered some of my questions anyway. Do we have questions?
I think I just had a runner.
Margaret Farley has a question.
So Jean, do you have a demand for people to serve as guardian or conservators that you are not able to meet?
So Margaret's question speaks to the referrals that come to us and what can be potentially be referred by some as a wait list. Part of the way I'm going to answer that, Margaret, is that that's a revolving list so that as we are able to meet the need, those people come off. Are there some folks for whom we maybe don't have a nominee? The answer to that would be yes. There may be other things that are being considered. We may have that referral and it may be being worked on, and maybe some lesser restrictive interventions. So that becomes, it may come off the books or it may not come off the books. So when I think about the people that are waiting for a nominee, one level is it happens with us. Once that nomination gets made formally, then there's that other layer of what needs to occur and waiting time, and then there's that waiting for the court piece in all of this. But in answer to your question, sometimes there are people. And so right now, my response is yes, and then I would put forth the challenge that we have many vulnerable Kansans who need an advocate and a voice. Whether that's guardianship or otherwise, those of us who are blessed need to step forward and be a voice, whether it's with us, whether it's with CASA, whether it's with any number of other organizations. I read an article just before I drove here today that said, and I can't remember the state, National Guards people are being called out to work in the IDD group home community. That's employees. Volunteers are not employees, but they are advocates and voices. And so I'm going to put that forward as something that, while we don't have enough, you can all help us expand the framework, the network of somebody who needs that challenge, or who thinks they can do it, or who will consider doing it after being in conversation. Long answer, Margaret, I'm sorry.
Further questions? Yes, Annette.
Hello, Jean.
Hi, Annette.
A question is, I see on the, that it can only be a referral from APS staff or the state hospital, and then there was some mention of financial eligibility. So if the individual has a higher income than Medicaid or SSBG, then what happens to that person? How are their guardian conservatorship needs met?
Or the undertone of that are not met. Yeah, I think it's a good question. There are many people, you're right, and we go back 35 years, you and I, Annette, and we work with those who don't have finance because there's not an option for fee-for-services. That being said, there's a whole lot in between those individuals and the ones who have resources or have resources for a short period of time. And so that then means that there's not a formalized system to identify a nominee for that particular person or situation. And then if it comes in via Adult Protective Services and they don't meet the criteria for us, then they're looking in the communities within their own networking abilities to try to identify some persons or person. As I mentioned earlier, there are some people who do this privately, and those individuals generally try to start out as a fee base, but sometimes those resources expire, they're exhausted, and so they in turn will sometimes continue to carry those cases. But there's not a formalized structure at this point for all the tweeners.
We've got a question online from Ernie Cutzley.
Thank you, Madam Chair. Ernie Cutzley, AARP, Kansas. Jean, thank you for your presentation. Can you talk just a little bit about working with veterans in the community? I know you mentioned the veterans, the VA is payee, but if a community member is a veteran and doesn't have VA supplemental income of any kind, referrals, or who does that, or are they just in the system? I didn't mean that in a bad way, but.
Right. I think I can respond in this way. Some of the individuals for whom we receive referrals, we will already know on the front end if they are currently receiving VA benefits. Once a guardianship or conservatorship is established, part of the discovery beyond that point is to see if there's anything in that person's history that would tell you whether they could potentially be eligible for VA benefits. And so it's sort of starting down that pathway to see what exists, what's available for that particular individual. And so because the VA has its own system for identifying fiduciaries, some of that is not necessarily go to the guardian or the conservator, but maybe a separate fiduciary entity that VA identifies. Not sure I completely answered your question, sir.
I believe you did. Thank you so much. One other question, if I may, Madam Chair. I saw your slide about volunteers and just wondering how you get that out to the community to look for volunteers.
So one of the things that we were able to do was to really upgrade our website, which hopefully then with hits, you're going to get a greater response. That's what they tell me anyways, for those people who are computer savvy. The other thing we do know, sir, is that some of the most successful recruiting is from people who are already doing this, believe in it. We do public presentations. We'll do those anytime, any place to talk about what we do. We do that with civic groups and organizations. We are always standing for invitations to do that. We have not found massive publicity campaigns as a successful way for us to do that because it's a pretty narrow interest area. But I would say to anyone, if you have my contact information, if there's a place where you think we need to place an announcement, information, here it's about, always we want those opportunities and we need your eyes and ears on the ground. We simply, as you saw our map size, we can't live in every county, in every community where we get referrals, and so we rely upon that networking from you all to participate.
Thank you very much. Thank you, Madam Chair.
Haley's got a question.
Hi, Jean. First question, in my experience when I've utilized calling to start the process of that guardianship conservatorship program, it's taken from start to finish anywhere from 9 months to a year. And a lot of that's more so on the court side. Would you say that that's still, I mean, I'm talking from start to finish, from calling in a report to APS concern investigation. Would you still say that that's about the average timeline? I know that average is kind of hard to determine.
Yes, it is hard to determine. I would say that in some cases you might have that time frame. In others, I would say it goes much more quickly than that. And I think the fairest way is to say it's on a case-by-case basis.
Okay.
One of the things that when you do work through the APS report center is that they have their own statutory timelines and what criteria needs to be met in order to screen in a referral, even if it ultimately down the road comes to the guardianship program. So what's important in making those reports is to articulate where the person is vulnerable and how they, in their ability or inability to make decisions, are leading them in directions that they might need support and assistance on. That being said, the other soapbox, and it's not exactly an answer to your question, is that there's guardianship is about informed decision making. What information am I receiving as a guardian? How is that information being presented? Do I understand it? Do I get it? Can I weigh the risks and the benefits? And in that conversation discussion, is there coercion? Is there subtle coercion on that? If you don't do this, this and this and this will happen. Those are things that have to be taken into consideration. So while guardianship is about making informed decisions, it is not a mechanism to force changes in behaviors, to force people to take medications. And I think that's one of the mythologies. I see Camille nodding her head, and Margaret and many others, because that's sometimes the motivational piece. And I'm not saying that in what you're talking about, Haley, but it just allowed me to launch into my other little soapbox there for just a moment, to know that it doesn't make it go away, people. And that's what many times we want to have. So I didn't completely answer, but.
No, you did. And it actually kind of leads into the next part of my question is what sort of safeguards are put into place while things are going in that process? Because if I reference back to the list of the order, it seems like an investigation is the very beginning of that to determine whether there are concerns. Can you tell me, like I said, what safeguards are in place while this is going through a process if it is determined that someone is not capable of, making those best interest choices for themselves?
So when there is an adult protective services report and investigation, part of their responsibility is to develop a protective service plan that is designed with the intent to begin to identify some helps along the way. Again, they're offered, they're made available. Some people choose to access them, some people don't. So that is a piece of what APS does as well along the way. So that's under their umbrella and not under ours.
Thank you.
Haley, did you have a follow-up you wanted to ask? Okay, you just, I kind of thought I saw a look on your face. Camille.
Thank you, Madam Chair. First of all, thank you for the guardianship program work across Kansas. We deal with guardians and with the Ombudsman program quite frequently, and rarely do we have a resident complain to us about their guardian through your program. So you do a really good job of supporting and training your guardians, I think, and what their role is and what it is not sometimes too. So I appreciate that. Do you ever have, you said something that made me think of a trend that we are concerned about and seeing that we are seeing where hospitals sometimes are using guardianships as a way to, I don't know, it's in their discharge work that they're using guardianships, and they're paying to have guardianships filed, temporary guardianships filed, particularly in some metro areas, and then have professional guardians. And we're getting a lot of complaints about those situations and those guardians, and sometimes either becoming really overly restrictive or absent. Do you ever get any of those, like after the fact, that once there may be some funds and they're gone, and so now they have no funds, and so then the guardian is no longer available or doesn't want to, they relinquish their guardianship. Do you ever get any of those?
The auto relinquish?
Yeah.
So what you're identifying is that it is something that we have seen and experienced through our eyes in the larger urban centers in particular. And that's because they want to be assured in their mind that somebody is providing informed consent, usually for placement, residential placement. And that is the mechanism by which they can move that through their system, rightly or wrongly. They're there for acute medical care, and they're less focused on the long-term aspects of what you and I would think about in terms of guardianship. One of the things I just want to add, because Rachel Pirner is also on the Kansas Judicial Council Guardianship and Conservatorship Advisory Committee, as well as there's a long-term care ombudsman representative, and that is a group that is systematically working through the guardianship statute. It hasn't been updated significantly since 2002, and I will tell you that what I know from across the country, it's time to do that, but it's not that antiquated. We did pretty well back then, and with a few tweaks along the way. So this is kind of an issue that I think could come back to that group to at least talk about what's happening in practice versus what could potentially be different.
Thank you.
And that's a good segue to a question we have from Rachel on WebEx.
Well, thank you, Jean, for all of the work that you do with the Kansas Guardianship Program and your other workers. As an attorney in private practice that practices in the guardianship conservatorship area, I've had plenty of experience with your volunteers, and they just do a great job. Tying back into a comment that came up before, we are in Wichita seeing quite a lot of hospital-initiated guardianships and conservatorships. And I've always attributed a part of that to freeing up bed space for the hospitals, that DCF is under such a crush. Their legal departments are under such a crush that in order for them to get the pleadings prepared, it is much more efficient for the hospitals to simply engage private counsel and to pay a stipend to a professional to have the individual transition to an appropriate level of care as opposed to going home. So that is going on. I think a big part of it personally has to do with funding and staffing on the DCF legal side and the economics of freeing hospital beds for the hospitals, quite frankly. So that's my 2 cents.
And that is a tension. You're absolutely right. One of the things to underscore, sorry about that, I didn't have lunch, I'll blame it on that, is that part of what is important to us as we think about all of this is what is the infrastructure that can support all the moving parts that are necessary in guardianship and conservatorship. If we need to make a change, let's say the guardian's moved out of state, or maybe they're aging out, or that person has health care issues. If it's within our system, then it stays in our system. If something were to come externally and Margaret would say, hey, I'm going to appoint the director of the guardianship program to be the guardian for this person, and that happens and I would want out, how do we identify the next round of people? So anytime we think about models and structures for how do things happen or not happen, is that each one of those parts of the stool, if you were the legs of the stool, how do we ensure those things are in place? And those are some of the bigger challenges, absolutely.
Okay, I'm not showing any further questions. So thank you so much for being here and for what you do, and your presentation today. I learned a lot.
And you have my number. You're welcome to call me.
We do. Okay, thank you. So next up, we're going to have the status of working group process. Yeah. Okay. We'll pause just for a second. There she is. Hina, we're at the point in the agenda for you, and
Thank you, Madam Chair.
welcome back.
Thank you, Madam Chair and members of the Senior Care Task Force. My name is Hina Shah. I'm a senior analyst at the Kansas Health Institute. For those of you not familiar, KHI is a nonprofit, nonpartisan educational organization. We're located right across the street from the Capitol. And I apologize for stepping out. I was talking to one of our work group chairs.
Bill's a troublemaker.
So in front of you, hopefully, is the work group charter, and all that is a culmination of the conversations we had at your last task force meeting. So I did want to go through that first and make sure everyone is in agreement with what is written on it. And so it starts out, it's a Senior Care Task Force Working Group Charter, and it starts out with the purpose on the first page. And so the product that was agreed upon is a report from the work groups that will then be presented to the task force for then review and finalization. And so the structure and scope, as we had discussed, would be 2 work groups and 1 subgroup. The Quality of Care and Protective Services Working Group would study the topics of the administration of antipsychotic medications to adult care home residents, the safeguards to prevent abuse, neglect, and exploitation of seniors in the state of Kansas, as well as adult care home surveys and fines. The other work group, which is access to services, will have 4 topics of study: the provision of care for seniors in the state of Kansas who suffer from Alzheimer's disease, dementia, or other age-related mental health conditions, the funding and implementation of the Kansas Senior Care Act, senior daycare resources in the state of Kansas, and rebalancing of home and community-based services. And as agreed upon, there would be a separate subgroup that would tackle workforce-related issues. Next, there is kind of a high-level goal criteria for setting recommendations that we can talk through at the next part of this. It talks about how the recommendations will seek to identify policy mechanisms. They'll think about feasibility, collaborating partners to make sure they're really actionable, and then any notes available related to equity or sustainability. The goal is really to think of something to support cross-sector collaboration, really defining mutual beneficial goals and engaging all stakeholders. The next part is really talking about the membership. So in your last task force meeting, you did assign chairs and vice chairs to each of the work groups, and I did have a chance to meet with them all last week. I will have remaining meetings this week to meet with all of them. And then content experts by those work group chairs have been sent to the leadership for appointments. These are non-task force members. And then legislators were assigned to each of the work groups as vice chairs. And then the leadership is available to join the meetings as deemed by their schedule. There may also be supplemental experts invited to each of these meetings based on the topics of discussion, and so those would also be individuals that are invited. So if you look at the last page, you'll see the membership in there, and organically, everyone that volunteered divided nicely among the 2 work groups and the subgroup. And so each of the work groups has about 8 task force members, which allows for 2 additional members without violating any quorum laws, and so we do have that there. And then we did go through the operating process last time, and then the timeline as well. One thing that wasn't decided upon is how you wanted to prioritize recommendations, if you wanted that done at in the work groups or then later at the task force. That decision, again, does not need to be made at this time and could be made next year. However, all that would do is kind of move up the schedule for the report being completed by the summer instead of early fall. And so that sums up the charter, and I'm happy to stand for questions.
Okay, members of the task force, do we have questions regarding the charter? Nothing? Wait a minute. It looks like there's a question from Deborah Zier.
Yeah, I'm just not able to find the material that that was just covered. If somebody can point me in the right direction for that. I looked on the website for the task force and I didn't find it where all the other documents from all the other presenters are posted.
Okay, on the website, on the task force page, there's 2 pages. Do you see
Yes.
up there at the top where there's a 1 and a 2?
Yes.
Can you go to the second page?
Yes. And then go to Hina's testimony. Is that all she was covering?
Well, we have another handout on goal setting, but
That must be that's what I'm missing, and also the list of the task force, the various committee membership. It's not posted here at this moment.
okay.
Maybe.
Okay, it's on the back page of the second page. Well, let's see, 1, 2.
It's on page 4 of the document.
Page 4 of the document.
Looking at Hina's visioning and goal setting PDF. Is that correct?
No.
Okay, well then I don't see.
It's the
Okay, let's see.
working group charter. Are others online having the same issue? You can see it?
Oh, okay. Well, just somebody that's watching online, could you send me the link or the document?
I think Arita is going to take care of sending that to you, Deb.
Thank you very much.
You're welcome. So we do have some other members that have been added. Am I correct?
So the work group chairs are sending other content expert appointments to the leadership of this task force for approval. And we will update this membership list once those are approved. So far, 2 additional contact experts have been approved, and a few others have been sent to the leadership for approval. As we update them, I will say that upon meeting with the work group chairs, the first work group meeting has been set for December 14th for goals and visioning. That's work group A. Work group B will meet on December 17th in the morning. And then the workforce subgroup also wanted to meet December 16th. And then for ease, another thing proposed, each work group has come up with kind of a recurring meeting, and the task force can see if that will work for their schedules, but quality of care and protective services. So work group A is proposing to meet the 2nd and 4th Tuesdays of the month. Work group B, access to services, the 2nd and 4th Fridays of the month, except in January, it'll be the 3rd and 4th Fridays. And then the workforce subgroup will start out in December, and they'll decide if they want to meet monthly or if they just kind of want to wait a month or 2 and then meet, since they are a combination of the other 2 work groups.
Okay, are there further questions? Yes, Annette has a question.
Do you have times for those meetings?
They're all 9 to 10:30 a.m. Get you bright and early in the morning.
Not all day like we keep you.
And they all will be 90 minutes.
Okay, I'm not seeing any question. Oh, I lost. Okay, I'm not seeing any questions. Do we need to vote on this today?
I will leave that to your direction, Madam Chair. It can either just be a document that you refer to, or you may make it official. I will leave that up to your direction.
Okay, I think I'd like to just use it, keep it as a document to work from at this point, until at some point when we have all the committee membership in line, then possibly we'll make it official. Okay? Do you want to move on to the next thing?
Sure. All right, we're going to work off the paper copy of the PowerPoint. All right, so now, Madam Chair, the leadership of the task force asked me to go through some visioning and goal setting. And so we're going to really think broad strokes and broad concepts here, thinking about it for the task force as a whole, and then direction for the work groups. Since the work groups will be kicking off next week, this is the task force time to really define what you would like these work groups to focus on, aside from just their topic areas, but give some other boundaries and parameters and criteria as well. So on that, I guess slide 2, that is visioning. So keeping those 7 topic areas in mind, and again, broad concepts and details. So now the bill recommended improvements regarding the well-being of seniors in the state of Kansas. So keeping your topic areas, again, front of mind, I want you to think through on slide 3 what it says, some of those questions. What does success look like for the task force? What do improvements regarding the well-being of seniors in the state of Kansas mean to you as task force members? What are important characteristics of a healthy community for seniors, for the senior population in Kansas? And how do you envision the lives of seniors living in Kansas in the next 5 or 10 years? In thinking through these questions, the task force can together think about a vision statement for your task force. And there are some examples provided on slide 4. So Madam Chair, I'll ask, would you like various task force members to raise their hand and provide a vision or some concepts around a vision? The other format I could use is just kind of go around the room and then ask those that are remotely to provide or share their thoughts.
Let's just raise hands.
Okay.
Okay.
And work group chairs, I know you're prepared for this, so please volunteer first.
This is Kendra Baldridge. Can I just, I've been listening, but can you repeat what the specific, like what specifically we're responding to, please?
Yeah, you're developing a vision statement. So what does success look like for your task force? So what are elements of this vision statement that you would like to set for this task force? What this helps with in the future is, you know, as recommendations are developed and you're prioritizing, you go back to your vision and you make sure it does align with that. So when we set up for thinking about the end in mind, it'll help bring value to that. Is that helpful?
Yes, thank you.
And so on slide 4, I've just provided some vision statements that other work groups, task teams have developed. And so one's from the autism task team and 2 of them are from the Special Committee on Mental Health Modernization and Reform, just to kind of give you some examples.
Sarah Schlitter, JCDS. And I did have just a couple thoughts. I don't know if you would like them now, but I kind of looked at your examples as well. And so one vision or kind of maybe broader thought I had for work group B would be to serve Kansas seniors who have Alzheimer's disease, dementia, or other age-related mental health conditions in a person-centered manner that reflects choice for their entire lifespan, no matter the location, modernizing services and having regulatory flexibility. That just means maybe not a one-size-fits-all service, as I think we've seen that that doesn't work. The focus is on health and safety while understanding that people are living longer and wish to remain in their homes, and that's a lot of verbiage, I know, but I just wanted to put in some thoughts I had over the weekend.
Thank you.
All right, since I got the look from Bill. Okay, so some ideas that I had put up for vision statement for the task force goal would be to serve the senior and older adult population of Kansas by creating a holistic approach to individualized care, best supportive services, and structural systems in a sustainable and replicable manner. So going along with yours. And as far as a work group goal would be to utilize a systematic approach to understand the needs of the workforce serving seniors in the state of Kansas, while discovering these needs, also creating a long-term approach to entice a workforce to return to and be retained within the senior services industry.
Wow. You guys have put some thought into this. Bill, did you have something?
I thought we were going to do that Tuesday morning, Chair, I'm sorry, at our first meeting. So.
Okay. Okay. Okay, so we're looking to the rest of the task force then to respond to these questions.
Any or all of them. What we'll do is based on responses, KHI will go back and craft maybe 2 to 3 different vision statements that you could review at your next meeting and vote on from there.
Camille, would you like to comment?
I love both of what I heard. The comment, I really like that we would use person-centered, that language. And I would have a distinction just a little bit between person-centered and individualized, because there is a tendency on individualized for us still to focus on power over and what that individual needs versus the person being the center of control of their choices. So that would be just a suggestion on that. There was something else in my mind. That's all I got today at 2:30. Yeah. It may come back to me. But other than that, no, thank you.
Other comments? Annette?
I would just want to make sure that under Group B for access to services, it's not just focused on people with Alzheimer's and dementia. And I have a little problem personally with the term age-related mental health issues. I think it's older adults with mental health issues. I'm not sure that it's age-related. It's just because that kind of goes along with some stereotypes about depression and older aging. So I just want to make sure that it's also for older adults and their caregivers and not just defined as these certain populations.
Camille. She's going to let me go again. Thank you.
Did you think of it?
Well, it did kind of go along with that it was not just, I don't know what's wrong with me right now. Apparently I'm dehydrated. I'm having some not age-related moments here. So that it was the piece about health and safety, that we would look at health, that we would look at a balance. Again, it's kind of going back to our balance that, and what we just were talking about with guardianships, that we are looking at, we are not just creating we are not creating systems that just try and solve problems by creating other problems. So we were looking at a balance between Well, a social model of care instead of just a medical model of care. That'd probably be the simplest way to say that for me. That emotional well-being is equally as important as health and safety. Sorry.
Online, I have Linda Mowbray with a comment.
Thanks, Chairwoman. Linda Mowbray, Kansas Healthcare Association. For group 2, I really did like the wording that Sarah used for the vision statement. But I do agree that instead of just singling out dementia, Alzheimer's, etc., that we go with a broader vision that all Kansans have access, and then go forward with the rest of her statements. And that if we need to put a caveat in there with special interest or special target for individuals with Alzheimer or dementia. But I would agree with Annette that, we need to make sure that it's broad enough for all Kansans to have access.
Would it be helpful to define seniors?
I think maybe it would. Haley?
Just a question to that. In the definition of seniors, my only to that is that some of the waivers that we have people on, some of your population in nursing facilities, et cetera, you were seeing younger and younger. So you're going to have some 20-year-olds, you're going to have some 40-year-olds that may not fit that senior descriptive thought, but are eligible to receive services provided by these programs. So I don't know if that is a clause or addition to not only the seniors, but those served by these resources throughout the state.
That's a point well taken, but we are the Senior Care Task Force. So, yeah, let's think about that for a minute. I've got Sarah, and then online I've got Ernie, Rachel, and Annette. So we'll go to Sarah.
I would second just what you're saying, only because I know for the population that we serve, we have many people who have a diagnosis of Down syndrome, and they are getting or receiving a dementia diagnosis, sometimes in their 20s or 30s. And so that, then brings along other specialized services or things that they might need to live as they, choose or, so I know that we are focused on Senior Care Task Force, but I guess I didn't even think of that until that was brought up. But wanting to just keep that in mind, as well as we do serve some people who, fall outside the range of 60 or 50 or whatever age we put in to describe seniors. Thank you.
Okay, next question from Ernie, or comment.
Thank you, Madam Chair. I would offer empowering people 50 and older to choose how they live as they age, including advocacy for what matters most to families, health, security, financial stability, and personal fulfillment.
Okay, thank you, Ernie. And Rachel Perner?
Thank you, Madam Chair. I likewise echo. I've got guardianship cases involving traumatic brain injury, and there are people that are much better schooled at this, but have also worked with some very young people suffering from frontal temporal lobe dementia. It almost seems like the senior services that are required by those individuals ought to be captured somehow by the committee. Thank you.
So I don't want to, just a minute. Wait. think I'll go back to, where am I at on my list? Annette, have you talked? Okay, Annette.
Well, many times today, but thank you. I'll just say this, that I think it's very, very rare that we've ever had the opportunity to have a focus just on seniors in a task force. So, okay, now can you hear me? So I think it's very rare that we've ever had the opportunity to have a focus just on seniors. So a senior care task force has been very, I think it's been a very good thing. And I think it's also because we have this crossover in a lot of the services that are provided will benefit others. I just think by the work of the task force and recommendations, a byproduct of that will be beneficial to many populations. But I've been very impressed with and happy to see a focus just beyond seniors. Now, when it comes to defining seniors, that's where it gets very tricky. So there's many definitions, and it's often by programmatic. Under Older Americans Act, it's 60 and older. By Senior Care Act, it's 60 and older. By the Medicaid programs, the FE waivers, it's 65 and older. When you look at job discrimination, it's like at 40. For our senior employment programs and senior centers, it's 55. Yeah, 40 and older. You like that one. So I think it's hard to define. Often the way it's been defined has been based on funding sources and how they define it. But often it's 55 and older, but most programs are funded for services. It starts at age 60. So just.
Senator Hildebrand.
Thank you, Madam Chair. And for those advocating for those that are not seniors, and I guess I just found out I might be able to get the senior discount when I go. So I will get with you and find out which category I need to tell them I'm in for sure. But we do address these other areas, like in the Bob Bethel Oversight Committee. And this committee is just, focused on seniors. So I personally would rather keep it focused there because we get too many committees talking about the same things. And especially if you're on multiple committees, you forget where you discussed what at. And so you can things can fall through the cracks because you think you've handled it here, but you didn't, you handled it there. So we do address those groups and other areas in the other committees. So I would recommend we just keep it to seniors.
If I'm hearing correctly, keep it to seniors according to the Senior Care Act of age 60.
I think we have a comment from Ida.
Madam Chair, do you believe it might be helpful if we read the statutory language that defines what the task force is assigned to do?
That kind of recenters us, so that's a good idea, please.
Okay. I'm reading from House Bill 2114, new section 1. There is hereby established the Kansas Senior Care Task Force. The task force shall study the following topics. Number 1, the provision of care for seniors in the state of Kansas who suffer from Alzheimer's disease, dementia, or other age-related mental health conditions. Number 2, the administration of antipsychotic medications to adult care home residents. Number 3, the safeguards to prevent abuse, neglect, and exploitation of seniors in the state of Kansas. Number 4, adult care home surveys and fines. 5, the funding and implementation of the Kansas Senior Care Act, KSA 755926 through 755936, 26 through 36, and amendments thereto. Senior Care Task Force resources in the state of Kansas is number 6. And finally, number 7, rebalancing of home and community-based services. Thank you.
Thank you. I think I was about to make some comments a few minutes ago, and I think maybe they were covered by other people. I just think that the purpose of this legislation to establish this task force was to have a focus on seniors for just to, what do I want to say, make recommendations as chair of Children and Seniors Committee. I feel like that part gets pushed aside a little bit. And that's why that's the purpose of establishing the legislation in the first place. And I agree with Annette that the byproduct of it will benefit others, but I think that's where the focus should stay. So are we wanting to establish an age for that definition, or are we okay with that?
I think it will be good criteria for when we are reviewing recommendations and thinking through, does this lend to why the Senior Care Task Force was established? I think that's helpful in that. And so it sounds like there will be kind of downstream effects for other population groups, but we will focus on seniors and maybe stay true to the definitions in either the Senior Care Act, if that's the topic area we're focused on, and with other topic areas, we can be a little broad where needed. Is that helpful?
I think so. I've got a hand up from Rachel Perner.
Thank you, Madam Chair. This was a useful discussion for me. I'm curious, we've got these federal acts that define what seniors are. Have we defined in our Kansas law what we consider seniors to be?
Jesse, could you respond?
Thank you, Madam Chair. This is Jesse Pringle with the Reviser of Statutes Office. So when we look at the language that I write reference in House Bill 2114, importantly, one of the things it references is the Kansas Senior Care Act. When you look to the Kansas Senior Care Act, that act doesn't have any definitions, but it is in the section for the Kansas Department of Aging and Disability Services. And in that act, one of the definitions to be used within that chapter of the statutes, it can be found in 755902, and that's a statute that states that aged or senior citizen means a person 60 years of age or older. And at this point in time, that's the only definition I've found in the statutes.
Thank you, Jesse. Rachel Munger, do you have a comment?
Yeah, I could be mistaken, but I'm also pretty sure that they define the age parameters in the Kansas Consumer Protection Act, as well as mistreatment of an elder person. They also have ages there.
Are you further confusing us?
I'm just saying if you're looking for definitions in Kansas
Okay,
law,
thank you.
they have those as well.
Thank you.
So we will put this on the work group's agenda to try to figure out what ages they want to define for each of the recommendations, and it can be criteria we use, which helps us segue actually to thinking about goals and parameters. So before I go there, a very wise person handed me a book a long time ago, so sorry, I'm going to tell you a little bit about myself. And this was during my formative years. It was a book by Steve Covey. So you always should begin with the end in mind. It means to start with a clear understanding of your destination. It means to know where you're going so that you better understand where you are now, and so that the steps you take are always in the right direction. And so that's why we started out with visioning, and now we're going to think through some goals. And this is kind of how I live my life. All right, so goal setting. Now, the bill did provide some direction. It did say recommended changes to state statutes, rules and regulations, policies, and programs. So pretty broad strokes there. So as we're thinking through some of these criteria, what are some goals or aims of the task force as a whole? And then what would like the task force like to direct the work group to accomplish? And I know my work group chairs have thought a little bit about this too, but I will give some examples. So things you could think about are, develop no more than 2 or 3 recommendations per topic area. Think about some that will be more actionable in the near term over 1 to 2 years, and maybe 1 to, that's more strategic. Start now, but it'll take 3 to 5 years to complete. You could consider populations of focus, so not just our older adults, but also think about rural and urban, as you discussed with broadband earlier. Think about low socioeconomic status, perhaps race and ethnicity, when developing your recommendations. And then whether the task force chooses to or the work group chooses to, how do you want to prioritize these recommendations? What criteria do you want to use? Because you could start from a list of 10 to 20. The goal isn't to make these super recommendations that are really hard to achieve. It's really to make actionable recommendations. So if you start with a list of 10 to 20, how will you prioritize those and let them bubble up to the top? Is it, things that are low-hanging fruit, so easier to accomplish now? Is it knowing, since you are on several different committees, what are other committees doing so you could make a collective effort? So what are some criteria that the task force want to think through and also direct, aside from age, the work group to really tackle and think through as they are meeting more often? So I'm going to look at Haley first.
Okay, so as far as the workforce subgroup, I based a lot off of the examples of the goals given, agreed with trying to develop 3 recommendations per topic area, low-hanging fruit, long-term goals. Considering it seems like a lot of focus we've talked about is rural versus urban and trying to build our goals based on that. I say an individualized approach, but person-centered approach in those environments, resources, et cetera, are highly different and oftentimes not replicable or scalable, as Bill alluded to. Prioritizing recommendations, trying to use following criteria would be timeliness, as we just discussed, cost of the initial investment, if there's any programs, current legislation that's already in place that would support the implementation versus the need for new proposed legislation, trying to prioritize based on that. And then as far as the workforce subgroup, and this is where I've identified a few, but would be very open to other interpretation. Looking on our working group charter page, the topics that were put under work group A and work group B, since the actual workforce subgroup is a collaboration of those, trying to identify the sectors and populations that are served and being served in that. Since we're going to be talking about workforce, it seems as if the working group A is more so the senior living institutional type setting. So looking at the workforce in that environment, whereas the working group B is more of your mental health and HCBS, I think it would be beneficial to try and define what industries we're looking at the workforce in, because I think you'll have a totally different approach of mental health versus HCBS versus skilled nursing versus assisted.
Thank you, Haley. Any others?
Chair, I apologize. Bill Persinger from Topeka. I have nothing to offer. I thought our first committee meeting was going to do this, and so I am not prepared, other than the remarks I've made about scalability and public safety and things like that. So I apologize. I misunderstood the task.
No problem. You always have a lot to offer, don't say. Sarah, did you?
Sarah Schlitter, and I had some of the same thoughts. I looked at the examples that were shared with us, and so really looking at rural and urban areas and making sure services, no matter the location, really focuses on person-centered approach while understanding maybe that there are different challenges and opportunities presented in different settings. And then I also had some ideas of just collaboration and sharing of resources. And I think that, at least in our IDD field, we do that fairly well at times, and sometimes we could definitely improve. But we all support older adults, and instead of each kind of reinventing the wheel or inventing the wheel, sharing resources to better improve our partner providers too, so that there can be a continuation of choice versus just one provider, especially in smaller areas. And then was just really open to our December 17th meeting, where I'm sure my coworkers and other participants will have a great deal of insight as well.
Are there others that have comments?
So, Madam Chair, I know that the bill does require you to basically present an interim report to the 2022 legislature and then a report to the 2023 legislature. So while that is a long time away, if there's any parameters or ideas or criteria we want to think through for those reports, the working group can serve as kind of just the starting point, and then the task force can take it from there.
Yeah, that'll work for the report to the 2023. I think we're going to work on the report today for the 2022.
And if there are no further comments, next week when all the work groups meet, we will make sure we summarize those visions, and they'll also be going through a SWOT analysis. So really looking at successes, weaknesses, opportunities, and threats in each of those topic areas. And so a summary of that and kind of getting everyone started may help to think through some more criteria at that point.
And just to make sure that we are following the rules for open meetings, we won't all be notified. I'm making an assumption that only the people on that working group will be notified with a link for the meeting.
Correct. So we will be setting up invites for work group members only. If the leadership who hasn't assigned themselves to the work groups would like to join that WebEx meeting, I will leave it to the direction of the task force to let you know how many people will be joining. And so if it's 10 or less, we don't have a quorum and we can meet. And Jesse, please correct me if I'm wrong. And if we exceed that quorum, then those members could view using Harmony or the YouTube link.
Okay, that was my follow-up question. Did you have a comment, Jesse?
This is Jesse from the Reviser of Statutes office. Yes, as long as you still remain under that 11 number, it's not a task force notice, but it would be a working group notice. And then it would be a working group on Harmony and Livestream, but not a task force one.
Okay. Could we have those dates one more time for
Sure.
this month?
And I apologize, I know that there are some conflicts with those dates. So Working Group A, Quality of Care and Protective Services, will meet on Tuesday, December 14th from 9 to 10:30 a.m. Working Group B, Access to Services, will meet on Friday, December 17th, 9 to 10:30 a.m. And the Workforce Subgroup will meet on Thursday, December 16th from 9 to 10:30 a.m. So all three will meet next week. In the future, however, Work Group A will meet the second and fourth Tuesdays. So please come prepared to discuss if there are any conflicts. Work Group B would meet the second and fourth Fridays of the month, except in January, it'll be the third and fourth Fridays. And the Workforce Subgroup will meet and decide if they want to meet monthly or kind of push back. One other thing since there has been a lively discussion on broadband, is WebEx versus Zoom. If legislatively, we should be using WebEx and Clois to ensure live streaming, or if we want to at times use Zoom, if it's more stable. And I think I will go with the direction of the task force.
Does anyone have a comment on that? You know, with the legislature, we use WebEx all the time, and that works really well. I have sometimes where I live in the rural areas, I have a little less stability with Zoom. I don't know if that's the same as what others experience. Does anyone have a problem with WebEx? Okay, we'll help you with getting something downloaded.
And thank you for bringing that up, Jan. I know what's worked well in the past is when Clois has set up kind of practice sessions that work group members and task force members can attend so that they become familiar with the technology. So we can work with them to make sure we set up a session just to test your systems.
Representative Esau.
Just a minor comment that some of us have found over time. If you're having trouble or it seems to be cutting out, turn off your video and make sure you mute. In fact, that's the key. Make sure you mute so that we're not picking up the fact you're typing on your keyboard or your cat's running around meowing at us and all those fun things. Right, right, because our other people in the house are going, what do you mean you're in a meeting? Yeah, so but definitely the video can make a difference and make it so your bandwidth works better, so you're not cutting out so much. And sometimes I can't do that special fancy background either. That will cause me trouble as well. Just things to try if it's giving you trouble.
Okay.
Thank you.
That's all. That's it for you? Mm-hmm. Oh, that was easier than I thought it was going to be. Thank you, Nina. Okay, we are to our last discussion item, and that is for the recommendations. What was a tiny list of 2 potential recommendations has turned into a rabbit and multiplied. And I'm trying to think if they're, okay, he's passing these out. If there's a way that someone might suggest, we'll start digging through these, and then if someone has a suggestion of how we might expedite them, please feel free to make any suggestions. I think that I have not looked through these yet myself. If we have recommendations for to look into something, or we just want to be careful that we're not making recommendations to the legislature that we actually want to make to the working groups. So keep that in mind as we are going through the, we could just quickly just say that's a working group item. Yeah, and as we come upon, because we weren't coordinating these, as we come across ones that are identical or nearly identical, we'll try to kind of just move through those quickly too. I think that the idea that that we don't end up with a real long list is possibly a good idea. Like Hina was mentioning in her presentation, it's much more workable if we just have a few. I don't think that we'll make any effort to prioritize these today, but we'll just go down the list as is. So that number one is creating a separate Senior Care Act okay, let me start over. Creating a separate Senior Care Act-like program to provide services to persons with younger onset Alzheimer's disease with its own funding allocation that would go solely to that population and consider the specialized services needed that would be different from this population. Is there anyone that would like to claim this, this recommendation and make any further comment, or anybody? Representative Owsley.
I would ask if this goes against the conversation that we just had on focusing upon seniors as it's younger onset Alzheimer's disease. Would this be a recommendation that could be one that's benefited downstream from this task force charge? I just throw that out there for discussion.
Any further discussion? Jamie.
Yes, I would just agree with Representative Owsley. It's for younger onset, it'd be under the age of 60. So if we just define 60 and over, what we go with, it would be under that age.
I would agree with that. I think that it's a good recommendation, but maybe does not belong in this report. Is there any objection to moving on? Okay. Next one, adding regulations for assisted living centers and appeals protections for residents for involuntary or improper discharges. So that sounds an awful lot like when you go down to the fourth one, that HB 2004 is Charlie's Law. I'll just comment on this from my experience that we had in Children and Seniors and made the recommendation to forward this item to this task force. I don't believe that we, in my opinion, are ready to make this recommendation yet because we have not had the opportunity to discuss it. We also have a request to the Judicial Council. It's late, I can't talk anymore. Judicial Council to request a study of this issue. So if there's no objection, I think that these, they're not ones that we, how do I want to say that? No, they're not ones that we won't consider, but maybe need to say that that goes to a working group. Okay? Margaret Farley.
Thank you, Madam Chair. So I thought the direction for submitting these recommendations was that it would come out of something that has already been discussed. And I don't know if we have a solid, but I think it can stay in as a point of discussion because there was testimony received on that from Rachel M. Thurn, maybe others as well. So I would vote for it to stay in. I don't think it's contradictory if Madam Chair, if your committee has sent it to Judicial Council, which I wasn't aware of, so I'm glad to hear that. But this is an independent body. It's not necessarily I mean no disrespect, but it's not necessarily the decision of your committee.
Oh, no, I didn't mean to infer that at all.
Yep.
But we are making recommendations to the legislature at this point. There's nothing that says that this cannot be further discussed in this task force and further studied. So we're not cutting it off. We're just saying, we are writing a report, a year-end report to the legislature. And to say that we're ready to advocate for passage, I would say is premature.
May I?
Yes?
So can a report not include one of the actions being there has been discussion in the Senior Care Task Force of, from various sources asking the task force to consider this as an action item without saying this recommendation equals a recommendation to do legislative, to make an immediate legislative recommendation.
These are recommendations. That's what our final report is. They're not our final report. Our interim report is, these are recommendations. And so we had, our committee made a recommendation to refer this to the Senior Care Task Force. So it's here. It's an issue that's here. We have not yet studied it, are not prepared to make a recommendation back to the legislature. We're not done with this item yet.
I guess I must defer to you.
I'm sorry, you what?
I guess that I must defer to you because we've gone back and forth now 2 or 3 times. So you're the chair. I guess you're calling it. Thank you.
Rita?
Madam Chair, I think it might be helpful for them to understand what goes into the report. And the report is not just a list of recommendations. It will include that at the beginning. That'll be at the end of the report. It'll reflect what those recommendations are. But the body of the report will discuss what this committee has talked about and what we've heard over the course of the meetings that we've had. So discussions on topics such as these will be included in that report as part of the body of the discussion that occurred.
Yeah, and thank you for that clarification. So what we are going through are what will be added, the list of recommendations. Does that clarify it?
Yes, and just what Rita said is exactly what I was discussing with you.
Okay.
Thank you.
But yeah, those are not the issues that we're going through right now. So if it's just something that we have yet to discuss, we will be moving past those.
Madam Chair, when do we see this report and vote on this report?
Our timeline, Arita, is...
Our hope is to have the report ready by the time the session starts. It may be a little bit later than that since we are just now getting around to finalizing our recommendations. And realistically, it'll probably be closer towards the middle of January. But we're doing our best to get these done. They'll receive copies of the report when it's finalized and will be sent to them for approval as well.
Thank you, Madam Chair.
Lee.
For sake of the rest of our meeting, is it safe to say, as I'm perusing through a lot of these, and I know we're going to go through each one, and we should appreciate that, by the way, that probably a lot of these are going to fall in that same category?
Yeah.
Okay, thank you. I just
Lee,
keeping
did
that
you
in
have a
mind.
comment too?
Thank you, Matt. Oh, thank you. I was just going to recommend that this definitely be a topic in work group A, and it needs to be discussed further. So I don't really need to say anything more. More was said after I raised my hand. So.
Okay, so that actually includes the next 3, that includes 3 items, down to the recommendation to pass House Bill 2122, enacting the Supported Decision-Making Agreements Act to provide a statutory framework for adults who want decision-making assistance. That was submitted by Jamie. do you want to make comments?
Sure, Madam Chair, thank you. I mentioned this one because it was brought up today at the guardianship presentation, and it is currently pending in the House, so thought it might be relevant to discussion. I understand if it would need to be sent to the working groups. So.
Is there any objection to sending that to the working groups? Okay. Legislation to provide at least rudimentary regulatory oversight of temporary staffing agencies to address poor quality and unreliability of services by these agencies, exorbitant fees for long-term care providers and the state. Potential legislation should include establishing a state registry, creating a basic regulatory framework, and setting upper payment limit parameters. That's from Deb Rozier. I think that's another one that we've actually had that in committee before, had a hearing on it, and not that that matters in this situation, it still needs to be discussed. So is there any objection to sending that to a working group? Haley.
I would agree that I think that's appropriate for work group, and I believe workforce subgroup would be the best for that, along with the very next line, Linda Mowbray's recommendation. And then a question for those of us a little late to this function. I know that this topic is discussed in many other committees, several of which I will be seeing some of you next week to testify for. Are there points that we need to know in this discussion of what is relevant to be discussed here, what is more appropriate for a different committee? Because I see where it overlaps. I don't want to exhaust time and resources where it may be farther along or best discussed in another committee. I guess I'm asking for a little bit of guidance on that.
Representative Ousley.
Thank you, Madam Chair, and I may not be the best person to address this, but like the senator just a moment ago, he said we're working on this in other working groups. So I think it relevant to bring up wherever it fits in, because as whatever, special committees or task force or interim committees are discussing whatever, if the same recommendation keeps coming up over and over again as all these committee works, are woven together, it just makes the plea stronger when it comes to the legislature as a whole. Doesn't mean you need to spend a whole lot of time on it, but I would think that somebody would say, thank you for bringing that up, we'll add it to the list, we'll put this down there. So I think it strengthens the need for whatever's the issue is at hand.
The Madam Chair, follow-up question to that, if I may. I don't know, is this the appropriate time that we are making requests for next meeting, or is that to be waited on until after this?
We're just having discussion, so now it's fine.
Okay, then I would ask that we do have some presentation to us regarding the staffing agencies to this committee, not only from some actual staffing agencies that serve within our state, but also from the providers that receive those services. I think it would be very, very essential to hear.
Okay, thank you. Note, that's noted. Did you have something? Representative Ousley.
As the chair of the workforce subgroup, I believe that's something that you could also get together with your vice chair and bring them to the subgroup as well, where you can dive into it as necessary as you deem necessary.
But good recommendation, because I think that, I don't know that I know I had this discussion with Hina, but we would like to have testimony at task force meetings and discussion at the working group meetings. That doesn't mean you can't have some testimony in your working group, but great recommendation there. Okay, are we ready to move on? Let's see. And while we're talking about this, we keep in mind when we're sending an item to discussion in a working group, we also can make recommendation for the legislative committees to have hearings on a certain topic. Now, like with Charlie's Law, we've had hearings and asked that it move to this task force. So we don't want to just shift it back and forth or nothing will ever get done on it. Okay, next, examine and modify HCBS FE rate setting methodology to promote further rebalancing, fairly reimburse providers, and offer more choices to CanCare members. What would you like to do with that? Senator Hildebrand.
Madam Chair, would that be something maybe we could request maybe a fiscal note given to each chamber's Ways and Means and I don't know what you guys call it, Appropriations Committee? Appropriations, all right. So getting some house training here. So would that be appropriate just to maybe make a request on this issue to get a fiscal note and have those two committees review that?
Yeah, certainly. I think that's also something that fiscal note that we might want to have a discussion in CanCare oversight in Bethel. Okay. So we will ask for a fiscal note on that. Okay, develop a map that shows where various senior services providers are throughout the state. Nursing homes, state license only adult homes, CMHCs, and aging specialists. Okay, just listing them all. I think that we did request that. And KDAD said that they yeah, just got some software to work on that. So I think that request has been made. I don't know that we would need to make that a recommendation to the legislature. Any objection to moving on? Seek assistance from universities to help with mapping of services. Well, that was from Deputy Secretary DeBoer.
Madam Secretary, or Chairman?
Yes.
That I had raised my hand before we left the last issue for that reason, because the next light item is that it appears that the agency, although they have their software mapping, their mapping software in place, that they are wanting to seek expertise from university contract to actually use that. So I would suggest that we get more opinion from KDADs as to what they're needing in order to get that mapping done before we move too much further on that.
Senator Hildebrand.
Thank you, Madam Chair. And I think what we would want to do is request that KDADS reaches out to universities and come up with a solution and a working agreement with that.
Thank you for that. That also includes your recommendation and I guess Linda's too on that page. Okay. So that includes all of those mapping. We can put that all in one recommendation and ask KDADs to work with the universities. I guess let's take a vote on putting that in as a recommendation. All in favor of supporting that, please say aye. Opposed, no. Okay, thank you. We'll move to the next page. Flying right along here. Expand funding for aging mental health specialists at all CMHCs. Jan, do you have a question?
Have we identified where community mental health centers are? There seems to be, there used to be a lot.
Well, they are identified, but I don't know that we've received a map.
Where we live, we're supposed to take part of Crosswinds, which is a regional group out of Emporia, but so that's Lyon County, Morris County, Chase County, and Wabunsee County. So it's not,
Chairman? Chair.
Yes, Bill.
I'm sorry. Kyle's testimony alluded to that, from the Association. There's a website we can get a map from and show where the community mental health centers are. There are 26. They cover all 105 counties. I think we heard that 30% have specific programs geared toward the aging or the age-related. Not all the same kind of programs, not all the same breadth. Some, fairly small, others, may have a more significantly sized program, but specific programs for the elderly, regardless of the age that we use to define that, are not prevalent in community mental health centers. And so, I'm a little prejudiced towards community mental health centers, including Crosswinds, where I used to be the chief executive. But, sure, I really do think that more resources are needed out there in the field. I just don't know what the cost of that would be or the scope, because what that looks like in Greensburg is going to be different than what it looks like in Topeka. But I know we've already talked about the importance of scalability, and not that everybody agrees with that, just something we've touched on a couple times. But I know that your public mental health system would be, I think I can speak for them, more than willing to engage and follow through and, get better programming going, more extensive programming. If that's helpful to the conversation, Chair, I would offer that up. And we can, there's a website you can go to and look at that map pretty quickly. I'm just using handhelds here. I don't think I could probably get to it myself, but if it's important to look at that now, I'm pretty sure staff could find that. We could get, if they could, as a way to technically get it up on the screen, we could take a look at that map and you can see where the mental health centers are located, including a list of their phone numbers, addresses, things like that. So if that's at all helpful.
Well, I think it's important information. I don't think that it's adds that much to our discussion at this point, because the recommendation is to expand the funding for, those CMHCs are going through some transition time and phasing some things in. I think this might be a little bit premature as well, and is prime for some discussion in a working group. So if there's no objection, I'll keep going.
Here. I think that's wise, I think, to jump too soon and say, well, we need this or that. And the services are needed, and I would agree. And thank you for that foresight.
Thank you. Okay, next, address barriers to those waiting to allow requests for eligibility determination to avoid those individuals having a 30-day wait when transitioning from a nursing home. Camille, do you have any further comment, or what?
I think that's more of a policy issue within KDADS. I think is what the issue was on that, and I don't know how we can handle that from here.
Is it something that could be addressed, discussed in working group?
Absolutely.
Okay. We'll pass that on to a working group. Next one, reauthorize use of trained temporary aides in long-term care to help supplement care for residents during the workforce crisis. We did discuss some temporary aides. Senator Hildebrand.
Thank you, Madam Chair. And that is actually a topic we're going to bring up in the Bob Bethel, and that's probably going to be one of our recommendations in the Bob Bethel next week. So, but it does not hurt to have a recommendation coming from two committees. And I believe our recommendation in the Bob Bethel will be something similar to just drafting legislation to introduce legislation to address that.
Okay. Representative Owsley.
Thank you. And so, Senator, would we want to maybe make a recommendation that the legislature explore this? That way, if the recommendation comes from the Bob Bethel group, there's at least interest coming out of this group as well to get to the same outcome. And it seems to go along with the next recommendation also, reauthorization of temporary nurse aides.
Representative Owsley, I would. I'd make that as form as a recommendation.
Okay.
Any further discussion? Camille.
I'm so sorry, but yes, I appreciate the language of exploring that and looking at that because it certainly is short-term needed. But in lieu of what we hear about more education and training needing for staff for good quality care in nursing homes, I do want us to be careful about that just being a long-term fix or a recommendation as a long-term fix.
I'm interested in some of the discussion that we had yesterday on these temporary aides. It's come from patient advocates. I'm interested in the providers, both Lee and Haley, what your response is to the temporary workers.
Thank you, Madam Chair. I believe I see what Camille is saying. And if you heard what Deborah was saying earlier, we're not really going to be able to address any of the other issues if we don't have workers to care for the people that we care for. And so it's an immediate issue, and the temporary workers still have to fall under all of the regulations. We still have to train them just like we train every other worker that comes into our home. So that includes dementia training, that includes all of that training. We are still required by regulation because they care for our residents to do that. Having the ability to have an office manager or a dietary person help out gives us the opportunity to pull that CNA away for 2 hours and train them. Otherwise, that CNA is going to have to be caring for people, and it's really difficult to give them extra training. And so I think it could, if used well, it could solve a lot of different issues in that we could have someone for 2 hours or 3 hours in the afternoon. I could use an office staff that's a temporary aide so that I can train the ones that care for them permanently. It's an issue we're going to have to address immediately, or you're going to just see further deterioration of really at the end of the line, availability for services for the seniors.
Right. Did you have anything to add, Haley?
I would just completely echo everything she stated. And the main criteria for this from an educational component is the basis to receive the temporary aid is 8 hours of training that start that foundation. And just as Lee said, there's a continuation. Is it a long-term fix? No. However, those of us in the industry do view it as a stepping stone because the majority of us that have used them have successfully gone on then to develop into CNA. So it's like it's our next level step for immediate assistance to then create a career goal pathway that we've been able to successfully utilize.
Okay, thank you. Thank you. Bill, did you have?
Chair, yes, sorry, I didn't mean to speak too soon and talk over Haley. Well said over there. And so I think I stepped out of my confusion for a minute. And, we were talking about the aging mental health specialist. That is a topic for more discussion and, funding and policy and goals and all those things. I do agree that it's something we can develop and work on through working groups or some other process. And so we've tried before the use of temporary trained aides. Is that correct? So, we're it's
using
to reauthorize
them
it,
now.
right? And so my point is, it looks like some of that low-hanging fruit that I that we're kind of aiming for today that we can recommend. And so I support that versus the topic about aging mental health specialists. Yeah, I mean, that we could probably work that up pretty quickly, but it probably needs more. But since we've had experience with this issue, we feel pretty comfortable about.
Yeah,
Yeah,
it's
so-
currently in place, am I correct? Yeah,
Yeah.
no? Did it end with the,
It expired
experience
when
with
the disaster declaration for the state.
for the state? Okay, I was thinking of the federal one.
No.
Okay,
But it's
so
a
you're
pretty
correct. We do,
tidy subject. It's a pretty, you know
we
what
do
I
have the
mean? We kind of-
experience.
Yeah. Thank
Okay,
you.
so we would like to add with our recommendations to reauthorize use of, I'm sorry. Oh, Margaret.
Thank you, Madam Chair. Margaret Farley with Kansas Advocates for Better Care. This was pushed, and I think, hindsight isn't going to help us, but we were truly in an emergency when the temporary aids were used. And I think testimony at the time said, this is just going to be a temporary thing. So that's just kind of a segue into I don't know. This appears to be something that is important to the industry because of the shortage of staffing. And I understand that they are under tremendous burden right now. But I think that we are just looking at the industry side of this as opposed to the resident side of it. During this time that temporary nurse aides were being used, as far as I know, they did not have name tags. Residents were not given notice that they were dealing with a person that had 8 hours versus the 90 hours. I think that if you're going to go down this path, which KBC is adamantly opposed to, then I think at least there should be informed consent from residents or a warning or some information before they start doing whatever they're going to do with me in that bed. Also, so I think we need to, sorry, my other point, and I have several, but I'll just end up here. What is the practical difference? And what's the practical delay? Is it 3 weeks in terms of the 90 hours versus, okay, you can get it done in a day and a half? When you're talking about safety of residents, I know that need is pushing this. That is the reason for it. Understaffing existed before COVID. I'm very concerned about the safety of residents, and I'll just leave it there. I don't think it matters that much in the world of getting staff in by simply saying, well, rather than 90 hours, which is the basis, that's been the basis for a long time. That's in the law for a reason, and the safety is, I think, paramount. I think this is one of those things where the industry in a tight spot, not entirely without leading up to this with prior understaffing, which KBC has been complaining about for a long time. I agree that COVID happened overnight. I think that it is not something that residents who are in many situations extremely vulnerable to abuse, poor care, and especially if we're already understaffed. At a minimum, I think we ought to warn the residents, the family, and also require facilities, if this is a moving train down the track, that you have to require facilities to have licensed nurse supervision for that person that's tighter and more onerous than what is done now with nurses' aides. That's all I'll say.
What I've got over here yet first. I'll just say that to your comments, I had to just ask what the providers thought. This was a discussion that went on yesterday, so I didn't even know where the providers stood on this until just a few minutes ago. So, Senator Hildebrand.
Thank you, Madam Chair. And this is a topic that the Bob Bethel Committee has been looked into for quite a while now. And one of the good things about an emergency declaration that come out of this is you get a trial period to see how something is working. To my knowledge, as of today, there have been 0 instances where there has been something gone wrong with a temporary assistant. Whether we like it or not, no matter where you go, workforce is going to be an issue for quite some time. I don't know where you guys live or not, but I know I cannot drive down a road without seeing 20 help wanted signs in my little area where I live, and it's not going to get better anytime soon. So I stick with my recommendation that we do this. We've had a trial period. The trial period, to my knowledge, has went very well. It served a usage, and that usage now is needed long-term instead of just short-term. So I just wanted to address that little situation. So with that, I still am for my recommendation.
Madam Chair.
Haley's next.
I would just agree in favor of having been someone who's firsthand lived with the temporary aid. It was a lifesaver. It was, yes, there were some staff that we were able to brand new recruit into the environment. A lot of it was to expand within the workforce that we already had. So Lee and myself, for example, we were able to obtain, we're not clinically trained in the hands-on care arena prior to, but we were able to obtain that certification to be able to expand the services that we were able to provide. Sometimes those of us in buildings were running into circumstances where we had people, but those people, it was outside of their scope of practice. So it was able to expand upon that, and it didn't give free reins to sit here and provide all services. What services were provided were under the supervision of licensed and registered staff also. So there already is that oversight in place. And another reason for the intention of it that came out was because we were running into circumstances where finding clinical instructors to complete those 90 hours of clinical instruction was not possible because those nurses are already at a shortage also. So it was a shortage that created the inability to hold those clinicals to meet the CNA course. It was a great stepping stone that I don't think any providers that utilize them regret.
Representative Owsley.
Sure. I'd just like to remind the members of the task force that the recommendation was to have the legislature explore reauthorizing the training. That way we could have this debate in a committee room with a piece of legislation in front of us, subject to amendment, and move forward from there, because right now we're simply just discussing a recommendation for the legislature to explore a possible solution for a workforce shortage.
Madam Chair.
I've got Jan's next.
Thank you. I wanted to be sure we make a point that while this temporary aid working is explained to the patient, to the resident who's receiving that care, I know for a fact that my mother-in-law was quite confused when the cook took her to the doctor's appointment. And she said, and it was a man, and he, according to her, he came into the doctor's, she goes, he's the cook. He took me into the doctor's office. She did not understand. And it was, oh, a temporary, when I called, they said, oh, it's just a temporary thing. Well, she was shook. I mean, and so I want to be sure that if this program is going to continue, that they're real clear with the resident, and in our case, we have durable power for health care for her, that we know, but that when she tells us that such and such took her for a ride, and, you know, and then he sat her down for something, we just need to be sure that that communication is there and that we understand it as she's, you know, we're responsible for her, that somebody's not walking in off the street and taking grandma for ice cream. You know, it's just, it was a real concern. So I just want to be sure if when we get down to somebody's writing it down, that communication with the resident each time that temporary person's taking them somewhere or performing a task, you know, that they feel safe, because as quickly as it happened, safety was not, you know.
Okay, thank you. That'll be part of
Yes.
exploring.
Yes.
Bill.
So, thank you.
Madam Chair, I hope I didn't miss it. When are we supposed to have a document first in the hands of the legislature, whether it's a committee or a committee chair or the full body? What's the first when is the first document that we're required to have? I hope that wasn't stated and I just missed it.
Yeah, Iraida talked about a timeline a few minutes ago. Do you want to briefly say that again?
I might have stepped out of the room. I see, you know, January and April on here, and I'm sorry to be, and then I have a follow-up comment.
The ideal goal would be to have it to the legislature when they come back in January. Realistically, we're probably looking at middle of January to possibly the third week of January before the report would be ready. We're moving as quickly as we can.
And I thank you. I did hear that, and I understood that, and I hope my next comment is relevant.
So I would just add that this is a year-end report, that our final report will be next year, this time next year. Okay.
And so I don't know if maybe this is a preliminary report or just how to maybe think about that, but it is a first report, an initial report. And if in that report, some of our comments or all of our comments are around this task force is recommending for further study, fill in the blank, and referring now to the legislature, that this is something we can refer to you now, legislators, in mid-January, late January, that we're referring this subject for further study. So if we think about, we're not making a decision today that, yes, legislature, this is exactly what we want done. We want to refer this to you, to Bethel, to another, the issue of temporary. So back on the matter of aging and mental health specialists, back on the matter of KDAD's mapping, you know, would I be correct in saying we could today even make a recommendation to the legislature that they study these things rather than here's the answer. Here's how many aging mental health therapists we need. Here's how many maps we need here, you know, and
that's exactly what we've done. We've directed KDADs to work with the universities on developing these.
And that's something that we'll recommend to the legislature.
You know, I think we need to be careful in jumping in with a lot of things to send to the legislature to be studied, because then we end up with that long list where the shorter it is, the better opportunity that we have that it might be addressed.
And I wasn't advocating for any particular thing. I just wanted to get the scope of work for the next hour and a half in mind, that we are looking for some basic
hour and a half. You're going to be here by yourself.
I thought it went till 5 o'clock. Gosh, I got the meter till 6, Chair. So, okay, I think you know, I'm sorry if I'm behind the rest of you, but you know,
You're fine. This is new for a lot of people, and so I appreciate the questions. Senator Hildebrand.
Thank you, Madam Chair. Couple things. You could have saved a couple bucks and parked in the parking garage. But for those of you that aren't aware, this report will be sent to each chamber's committee that handles that particular situation. And then it'll be up to that committee on what they proceed with on your recommendations. So like the chair was saying, if you put up a lot, I don't know if you guys have ever seen committee members' eyes gloss over, but that will happen and you won't get a whole lot accomplished. So the more you can refine it and target it in, the better your opportunity is to have something meaningful come of it.
I will say that your comments about exploring, studying are well taken. I think if there's something that we are ready to make a recommendation on, that we can do that today, too. Back to Margaret for further comment.
Yes, Senator Hildebrand made the statement that we've already had a test of what temporary nurse aid services were in facilities. Unfortunately, the bulk of that was when families were not in the building. I don't know of anyone who has done any independent, objective, third party that has done any sort of survey with the residents as to how well that went for them. And so, in that period of time, so basically it's the resident and the staff of the facility that were primarily the people evaluating that. And right now, I think we're only hearing from the staff and the associations. And I don't think we should proceed on this believing that there has been a pilot or a test study. I don't know of any data whatsoever. If it's anything, it's anecdotal, and it's in the hands of people who work in and run these facilities.
I would ask, is there any harm in looking into it?
Oh, I would, KBC is not going to support even looking into it. At all. So I'm probably not your person that's going to ever be in favor
I guess
of this.
that's what I need to know. So,
Yeah.
Okay, so I don't see any further discussion on this one. So the recommendation is, the proposed recommendation, oh, now I'm lost, is to study the reauthorization of the use of trained temporary aides in long-term care. So all in favor and support of that, please say aye. Aye. Opposed, no?
Nay.
And those online, I guess I didn't discuss this before. You are welcome to vote if you would like to. If you have an objection, please let us know. Okay, I'm not seeing anything. Okay. All right, that recommendation passed. Moving on, have MCOs explore alternate supports to address the workforce shortage, such as an individual's strengths and abilities, supportive relationships, family caregivers, technology, shared living, and community supports. Camille, do you have comment?
My comment would be, I think that should go to a work group at this time, as well as my next recommendation regarding, but that's just I get those two out at the same time.
Thank you very much. Okay, next one, encourage career ladder, tuition grant program and/or loan repayment program. That's Jamie's. Do you want to comment?
Yes, thank you, Madam Chair. This is just something we're also addressing immediate needs for the workforce, but this would be more long-term need to help to encourage those to get into that career field. So I have it addressed to the work group.
Okay. Great, thank you. KDADS should consider raising the rates for in-home providers for the FEPD and BI waivers, and specifically require the providers to pass the rate increase on to direct service staff. That's Annette. Do you have any comments? Oh, yeah. We're covered on that. Okay. Keep going. The legislature could remove restrictions on licensures for APRNs. Currently, APRNs in the state must work under the supervision of a physician in a collaborative practice agreement, often paying out-of-pocket fees to the doctor each year. Ending these limitations would improve healthcare access across the state in rural Kansas. This is Ernie's. Ernie, do you have any comments on this?
I do, Madam Chair. So I was looking basically at licensing restrictions for long-term care workers across the state, or just health professionals across the state altogether. I think in light of time, probably my next 3 or 4 the data that's in those would go to the working groups.
Okay, thank you. Thanks for moving us forward. I'll say the APRN bill is an active bill currently in the House Health Committee. Is it in yours as well? It's in the Senate Health Committee as well. So as that is discussed, potentially discussed in a working group, that recommendation may follow, or the bill may pass before that it gets to that discussion, or not. Okay, so we'll drop down to the last one on that page. Look at a framework to support person-centered planning, where an individual's own wishes, strengths, relationships, and technology and community support we can all access or consider before we apply paid eligibility-based services. Sorry, I'm just running words together.
It's a lot to say. There's a really easy framework for that that makes it much easier that I hope to, we'll be able to look at. But I do think it's just to go to the work group. I do want to say, though, why I say it is that while it is regulatory required that this happens for HCBS and long-term care under regulation of both, that we have 3 MCOs who have I think all their care coordinators have been trained in person-centered thinking, and they have at least 1, maybe 2 of them have trainers in this state, and they have the ability to train providers and other stakeholders. And that if we would look at that in the MCO contracts, I think that would be something we could really get done to scale. And not just long-term care, HCBS, but in other areas. So anyway, thank you.
Yeah, thanks for that discussion. Bill?
Madam Chair, Bill Persinger, Topeka, is that a matter that Work Group A could take on? Or is that more of an access or workforce matter? For further study, did I hear further study maybe?
Yeah, well, I think we we can refer it to a work group. I don't know that we need to decide which one this moment.
Well, I'm saying if it comes our way, we'd be glad to take it on. Thank you.
Okay, great, thanks. Potential recommendation regarding broadband telehealth. And we appreciate Ernie so much because he actually put some numbers down there to support that. What might be your wishes on how you would like to have this worded? Senator Hildebrand.
Thank you, Madam Chair. I would like to recommend that we have a legislative post-audit look into broadband going to rural communities and to do a cost comparison between rural and urban communities and what their definition of rural and urban would be, and specifically to look at the funding that has already come into the state that was supposed to go to rural broadband, just to audit that to see where the funds actually went and how much went to each rural area.
Madam Chair.
Representative Ousley.
Thank you. And I'm not in disagreement of it. I just know that if we throw that into the hopper in the LPA, we won't have any data for a long time. Whereas I think to get an answer to where we're at as far as the federal aid spending, perhaps we could do they call them short-term audits. It's less than 100 hours. I would think that we get an answer pretty quickly that way. At least that way we know if the finances have been expended and what we can expect coming up as far as improvements for broadband across the state.
Yes, go ahead.
Thank you, Madam Chair. And I would amend my motion that it is a short audit under 100 hours.
Limited scope.
Limited scope, yeah, limited scope audit.
Do
Thank you,
we know when post-audit meets again? Anybody? In the meantime, Bill?
Madam Chair, thank you, Bill Persinger, Topeka. And if I sure support what the senator said. And do we want to also name frontier areas, urban, rural, and frontier?
I thought of that while he was
Okay.
talking as well. Urban, rural,
Outstanding.
frontier.
Thank you, Chair.
Do we want to make any, I mean, post-audit is great to look into where those funds have gone. Do we want to make any other potential recommendation? Senator Hildebrand.
Thank you, Madam Chair. And I know KLRD, they're not real busy at this point in time. Maybe that would...
Dripping with sarcasm.
That was a lot of sarcasm there. They do, for those of you that don't understand, they do all the work, not us. And we couldn't do anything without these ladies and gentlemen doing the work for us and getting us to research and everything. So that was a sarcasm heavily intended. So I do appreciate everything that they do. But maybe we could also, on top of that, have legislative research, do some research on that on the front end and give us a report back at a later time as well.
Okay, so let's take the first one on post-audit. Do we want to do it a combined? Right.
That's your choice, Madam Chairperson. I thought you would want to know December 16th is the next LPA meeting.
Okay, so we're going to make a recommendation. When is the next meeting after that one? I am never going to get my Christmas tree up.
I'm sorry, our calendar only goes through the end of December right now, so.
Okay, all right. So the recommendation is to have, what'd you call it? A limited scope, request a limited scope audit of the federal funding. Okay, any funding, including federal funding for broadband. Urban, rural, and frontier. Did I miss anything in that recommendation?
Madam Chair, if I may,
Yes,
just
go ahead.
that they also look at where the money went, what percentage went where, and what they define as rural, urban, and frontier as well.
Definitions. Okay, good. Okay. All in support of that recommendation, please say aye. Excuse me. Oh, we need Representative Owsley, second. We'll vote again. All in favor, say aye. Opposed, no. Oh, I'm sorry. I had some. Ernie, did you have a comment on that? No.
The specific infrastructure funding is going to be around $100 million for Kansas. I'm not sure where that falls in legislative research, where that comes to or goes to.
Ernie, I think we missed the first part of your comments or question. Can you repeat?
Yes, can you hear me now?
Yes.
Yes, I was saying I'm doing some other research that from the estimations, specific infrastructure funding for Kansas broadband is going to be around $100 million.
Okay, are you just saying that to have noted?
Yeah, I was just saying as we look or someone looks at funding for broadband infrastructure, that there's somewhere out there, a minimum, it says, of $100 million to Kansas.
Okay, thank you. Okay, and we had an additional broadband recommendation to ask KLRD to look into, to research the funding. Is there a second for that one? Okay, we have Bill seconded. All in support of that recommendation, please say aye. Opposed, no. Thank you. So we can move down to mental health. The state should establish mechanisms to ensure that LTSS agencies and mental health authorities address the mental health needs of individuals receiving LTSS.
Once again, Madam Chair, a working group.
Send it to a working group? Okay, thank you. Require CMHCs to provide mental and health and aging training for clinical staff who provide services to older adults. And Annette says we'll send that to a working group. And this next one from Linda Mowbray is similar, funding for aging specialists at CMHCs. And the next one, provide access for residents with level 2 mental health needs to be provided in the nursing home by a CMHC. Linda, are you okay with yours going to working group as well?
Absolutely, thank you.
Thank you. Okay, other recommendations. Provide dementia training, 4 hours of dementia training annually for direct care workers, 2 hours of training for new employees within 90 days of employment. Jamie, do you?
Working group, please, Madam Chair.
Thank you.
Chair, I'm sorry. I hope I'm not out of order, but back on the, Bill Persinger, Vallejo, back on the provide access for residents with a level 2 mental health. I'm, of course, maybe it's on down the line for further study, but the reimbursement through Medicaid could be a problem if it's provided by a community mental health center in a nursing facility. There might be, maybe there's some waiver issues to consider and other technical matters, just a point of note for whatever committee would get that.
All right, thank you. Where were we? Seek funding, is that where we're at? Seek funding and develop partnerships for the development and distribution of a new Kansas Elder Count book that provides the demographic and detailed data as the original Elder Count book. This information would be provided detailed and robust data to help legislature and state staff plan for current and future needs for older Kansans. I kind of forgot we had talked about that, Annette. Yeah, it was. Do we need to send that to a work group? Camille?
That has been a very useful publication in the past. I can't imagine that it would not be used again by everyone. I can't imagine, we can talk about it more and take the time to do that, but honestly, can't imagine that we shouldn't make that recommendation.
I would be good with it. Any other discussion on this one? Haley.
Just a question. Is the current one digitized already? Oh, okay.
Well, there's not a, Annette. We found it, but it's not, what do I want to say? It's the most recent, but maybe not current.
Okay.
Does that make sense?
I would just maybe add to it that with the needs, I mean, I believe we're kind of still in that age where, yes, we still need the paper, but also need to be looking at the digital format of that to move us forward.
And data too. You know, yeah. What kind of data is different that we would want in it? But yeah, I think it was the one and only, what year was that? 2001. I don't know, it's very old. Yeah, but it was great data.
Representative Ousley.
I was just going to say, if Annette wanted to make the recommendation, I'd be happy to second it, that we recommend the legislature seek funding.
And we have a second. All in favor and support of that, please say aye. Opposed, no? All righty. Research state licensed facilities providing HCBS care in 2018 versus 2021. Linda, do you have comment?
I believe that can go on to the work group. KDADS is, as part of their mapping project, they're looking at where those HCBS providers are. I know they've deferred to the MCOs, but I think the working groups could also look at some of that historical data so we can track how many providers we're losing.
Okay, is that one that, and the next, can those both go to a working group?
Yes, please.
Thank you. And there's none on the back. We are done. Representative Owsley.
Thank you. And just for committee members, back on the 2 no votes, I'm used to being a no vote in the minority in this building. And if you would like to have your no vote recorded in the minutes, you can request that. I just want to put that out there.
I thought it would be. Thank you. Thanks for that. Yes. To the recording of the minute. Oh. So I appreciate that. And yes, I would like the no vote recorded. Thank you.
And you indicated there were 2. I'm sorry, I missed if there was another one. Okay, Jan, did you want yours recorded? Yes. Anyone else?
Can I have it recorded that I abstained?
Yes. Camille abstained. Okay, that is the final item of business that we have for this agenda for today, for this meeting, for the year. And I'm quite excited about the working groups getting started next week. I hope you all are too. And with that, we'll adjourn and look forward to talking again next year.